Bhaskar sir, we are good to start.
Yeah, please. Waiting for that.
Yeah. Good morning, everyone, and welcome to today's webinar. Bhaskar sir, we are good to start.
Waiting for that.
Yeah. Sorry. So, morning, everyone. Welcome to today's symposium on pediatric cardiology. Cardiology is a very important topic and often a diagnostic dilemma for most of us. Practice. I'm sure by the end of important clinical clues, the diagnostic pointers in pediatric cardiology, especially on critical congenital heart disease. We have a wonderful panel of lectures and then a very interesting practical panel discussion towards the end. Please feel free to type in all your in the chat box. I already con and the revised dates now are 1st, 2nd, and 3rd of July 2020. And as a mark of respect and in loving memory of our very beloved late Professor Dr. P. Sudarshan Reddy sir, we dedicate today's academics in his loving memory. I can proceed with the session.
Thank you, Dr. RSV. Am I audible? Thank you, Dr. RSV. Am I audible to all the participants?
Yes, sir. Yes. Okay. Please go ahead.
Yeah. Respected faculty members, distinguished participants, good morning to you all and welcome you all to this 5th IAP Twin Cities monthly symposium on an interesting subspecialty that is nothing other than pediatric cardiology, and with an interesting, highly admired coordinator for the program, Dr. K. Nageshwar Rao. Today, as you all know, is a historic day in the pages of Indian Academy of Pediatrics. Just 2 years ago, on the same day, we lost a towering personality who is none other than Dr. Patulla Sudarshan Reddy sir. I'm sure all of you know him or you're all well acquainted with him. So just few words about a great person like him. He was a versatile person in its true sense. He served our Indian Academy of Pediatrics for more than 35 years, beginning from an ordinary member of IAP to the national level advisory committee chairpersons. Not only that, he served more than 35 years in premier academic institutes like Nilofer, Gandhi, teaching the undergraduates, postgraduates, pediatricians, and as well to his colleagues. Apart from academics, he was a great philosopher and a remarkable, renowned spiritual person and a great advisor to all of us. I'm lucky to be acquainted with him for the past 35 years. And whenever an advice was required, I used to talk to him. He used to advise me like an elder brother. So we all miss him. And I thought the minimal thing which we can do in his memory is to dedicate this symposium, today's morning symposium, and as well today's evening symposium to our respected, beloved Dr. P. Sudarshan Reddy sir. Words are not sufficient to describe about him, and time is also a constant to describe about him. But in nutshell, I can say he's a great legend, and as well is a father of pediatrics of 2 combined Telugu states. Without any hesitation, I can say these 2 words to him. He deserves to be a legend and deserves to be a father of this Indian Academy of Pediatrics of Telangana and Andhra Pradesh. And amazingly, all the faculty are well acquainted with him, starting from Dr. Nageshwar Rao to Dr. G. V. Subramaniam. All of you are very well acquainted and have good regards for him. And now coming down to our symposium, my special thanks to Dr. Nageshwar Rao. Despite his busy schedules and busy preoccupations, he tried his best to get the good faculty and good program, scientific program on a single theme, that is neonatal congenital heart diseases, and as well a panel discussion on the common pediatric cardiac problems which we all face in, day out in our practice. So my special thanks to you, sir, Dr. Nageshwar Garu, for organizing this symposium. And thanks to all the faculty members, Dr. Kavita Chintala from Apollo, Dr. Bhargavi from Rainbow Heart Institute, Dr. Jaya Rajan from Chennai, Dr. G.V. Subramanian sir from Vascular Medical Institute, Dr. Tejo Pratap from Fernandez Hospital, and as well, am I missing anybody, sir? Yeah, Tejo Pratap.
No, sir, everybody is.
So I sincerely thank all of them, and now I request our Dr. Nageshwar sir to take over the proceedings to conduct this symposium. And at the end, my special thanks to all the participants. There are more than 30 members at 9 a.m. That shows the interest of our participants as well the specialty of our faculty. So wish you all a great learning experience and a great knowledge sharing with this symposium. Thank you one and all.
Thank you very much, sir. It's indeed a great pleasure to be associated with IAP, our combined states. I thank you, and I thank Dr. Sri Krishna and other office bearer of IAP TCB.
Nageshwar sir, I'll just take a minute, sir. Is there anybody else who needs to be made? If you can just let me know, we're already be able to share screen. Dr. Kavita is here. Anyone else, sir, as of now? Dr. Kavita?
Yes, I'm here.
Could you just test if you're audible? Correct. Thank you. I think we're good to start. So I'm just changing the settings so that only co-hosts can speak and others will stay muted. All of you to please participate. Nageshwar sir. Sir, unmute cheskon Nageshwar sir. I changed the setting.
Am I audible?
Yes, sir.
Okay. It's indeed my great pleasure to be associated with our IAP, and I thank Dr. Bhaskar, Dr. Sri Krishna and other office bearers. I really appreciate and thank my colleague faculty members, Dr. Kavita, Dr. Bhargavi, Dr. Professor Jayaranganath, and Dr. Subramaniam sir, and Teja Pratap. We thought actually we should have focused symposium, and at the end we'll have some kind of a panel discussion that will give some education rather than having completed didactic lectures. So I will probably highlight how the clinical presentation is going to be in a critical congenital heart disease. My colleague Dr. Kavita will give important information pertaining to the clues to diagnose based on the available investigations. Dr. Bhargavi will tell about the functional echocardiogram and how it is going to be useful in diagnosing some of the congenital heart diseases. And Professor Jayaranganath, very experienced person, will demonstrate some of the cases who underwent surgeries and the interventional procedures. So you all know that postnatal circulation, as soon as a baby is born, 3 important shunts, that is ductus venosus, foramina ovale, and ductus arteriosus, play a crucial role in the fetal life. As soon as baby is born, the systemic vascular resistance will be increased, umbilical veins will be tied off, so ductus venosus shunt will be less, even though it will be opened functionally, which may stream blood from the liver, hepatic veins, and portal vein to the right atrium. And foramina ovale, as soon as the left atrial blood volume increases or return increases, as soon as the pulmonary venous resistance drops, then there will be increased LA pressure, functional closure of foramina ovale will be present, and the ductus arteriosus basically major mechanisms play a role, that is constriction of the smooth muscles and increased bradykinin levels and increased SVR and drop in PVR will cause constriction. So all these changes may actually bring out the complex heart diseases which are subtle in fetal life or dormant in fetal life. So any rise in acute systemic vascular resistance, which is not present in fetal life, if there is obstruction to the systemic outflow, like aortic stenosis, coarctation of aorta will present with ventricular dysfunction because of the ventricular arterial decoupling. So the conditions which present at various stages based on these, transposition of great vessel in fetal life, the oxygenated blood to some extent go to the lower extremities. That's why babies are born large for death, one of the mechanism. But foramina ovale and ductus will give some amount of oxygen. As soon as the baby is born, ductus will be closed, foramina will be restrictive, so they present with cyanosis. Obstructive TAPVR, in the fetal life, the blood flow to the lungs is only less than 8%. That's why even there is obstruction, you don't appreciate much of the high drops or right heart dilation. It will be only subtle or mild dilation. As soon as baby is born, baby takes breathing, pulmonary vascular resistance drops, so large amount of blood will go to lung. So pulmonary venous blood flow will be increased, obstruction will become more, they present with respiratory distress. Conditions like ductal-dependent circulation, pulmonary atresia, systemic outflow obstructions, interruption, they present based on the ductus arteriosus closure. Systemic circulations, they present much earlier than the ductal-dependent pulmonary circulations, because the circulating PO2 levels, oxygen levels in the body in ductal-dependent systemic circulation is much higher compared to the ductal-dependent pulmonary circulations. That's why the closure of the ductus arteriosus is much faster in case of ductal-dependent systemic circulation. They present much earlier. So when the fall in PVR is a rapid process in normal neonate, which can be 60% fall in the end of the first week, whereas in case of left patients or fall in PVR, increased pulmonary blood flow situation, they can present even from second week to 6 weeks of life, after life. So these are this timetable is very, very important from the teaching point of view, students' point of view. So heart diseases in neonates, reduced pulmonary blood flow, pulmonary atresia VST, pulmonary atresia intact septum, pulmonary atresia, any other complex congenital heart disease for that matter, or tricuspid atresia PS, they all basically dependent on the patent ductus arteriosus. They will have cyanosis and no heart failure. Whereas whereas increased pulmonary blood flow situation like truncus arteriosus, TOSIC being anomaly, total anomalous pulmonary venous circulation, or Hlhs, they can present with either shock if there is obstruction, severe obstruction to the venous return, or they can present with the cyanosis and heart failure. Whereas a normal pulmonary blood flow situation like a simple transposition of great vessels remaining or not pertaining to the neonatal group, they present with the cyanosis based on the time of closure of the foramina ovale and ductus arteriosus. The conditions which present shock presentation are hypoplastic left heart syndrome. During my post-graduations, I still remember that we diagnosed a lot of sepsis in neonate. Some sepsis after evaluation found to be hypoplastic left heart syndrome and coarctation of aorta. So they absolutely mimic like a septic shock, like a mottling, delayed capillary refilling time, low urine, acidosis, acidotic breathing will be there. Obstructed TAPVR, coarctation of aorta, critical aortic stenosis, all present like a shock presentation. So any neonate presenting with a shock, don't label only as a septic condition. You please rule out this before you declare that. Cyanosis is an important condition. It's a very unusual to miss that in the present NICU level 1, even level 2. It's very unlikely. Obviously, you may not see cyanosis in neonates in the dark-skinned individual, but we are all checking the pulse oximeter in all even level 1 neonatal units. So you will be diagnosing cyanotic congenital heart disease, especially transposition of great vessel or pulmonary atresia, whatever the anatomical context, we can diagnose. Heart failure is a tricky condition where they present much later than shock and cyanosis. It can be due to systemic AV fistula, vena of Gallan malformation, hepatic venous fistulas, or increased pulmonary circulation like a truncus arteriosus, total anomalous pulmonary venous return. All these things can present somewhat a little bit later because there will be preload dependent heart failure in all these conditions. So ventricles will take some time to go into failure. So it's basically preload dependent heart failure. Some severe heart diseases which cannot be diagnosed easily immediately after birth are all kappa, left coronary artery arising from the pulmonary artery. Because of the high neonatal PVR, their presentation is somewhat a little bit late. Conditions like a long QTC, unless you have a clear-cut suspicion, family history of SIDS or fetal bradycardia, you won't be able to diagnose unless they present with some kind of a torsades or you take accidentally ECG or you have a strong suspicion. Day 1 presentations, obstructive diseases, as I told you, are severe AV wall regurgitations, which is leading to the very significant cardiomegaly. First week to second week, ductal dependent systemic, as I explained you, and then subsequently ductal dependent pulmonary, and 4 to 6 weeks heart failure conditions they present. Whenever there is a progressive onset of cyanosis, low grade symptoms, then you should suspect any of the stable outflow tract obstructions like VST, PS, physiology, and other conditions. While you are actually examining the child, you have to take the history of drug intake in the perinatal period, especially NSAIDs. If you give, they will have premature closure of the ductus. They present with severe hydrops fetalis. Gestational diabetes, you all know, associated with increased incidence with detransposition of great vessel or hypertrophic asymmetrical septal hypertrophy. Birth asphyxia sometimes can cause AV wall regurgitation and ventricular dysfunction. It will actually exaggerate PPHN in the presence of preterm babies. Intrauterine infections, again, may be associated with the congenital heart diseases. Nowadays, we are seeing COVID in the mother, perinatal COVID, and the neonates present with ventricular dysfunction. They respond very well to the gamma globulin. So is there any history of any documentation of fetal echocardiogram is very important in these babies to have some kind of a diagnosis. So the clinical physiology is essentially based on the transitional circulation, closure of the ductus arteriosus, and the fall in PVR. This will lead to the either parallel circulations like a transposition of great vessel or critical obstructive conditions like critical aortic stenosis, ductal dependent circulation, or heart failure conditions. These are the pathophysiological mechanisms which present that. So transitional circulation, how the duct, as soon as it gets closed, in case of pulmonary atresias, the blood will not be circulated from the aorta to the pulmonary artery. So babies will present with a severe cyanosis, even sometimes a shock if it is acutely closes. They will have a respiratory distress. Whereas in case of ductal-dependent systemic circulation, the pulmonary artery will not support the systemic circulation, and they will have acidosis and renal failure, and there will be right heart dysfunction. So don't think that the coarctation and aortic stenosis will have only left ventricular dominance and left ventricular failure. In fetal life, it's a right ventricle which is actually more working than the left ventricle. As soon as baby is born, right ventricle also will be under stress, so that they will have right heart failure. The precordial pulsations will be very large and they develop a tricuspid regurgitation also. So you can see the example of a baby presenting with acidosis. I will not touch these things essentially, but I have to show one or two pictures somewhere because my subsequent colleagues will be talking on that. So babies will present with acidosis, respiratory distress, capillary refilling time, and reduced urine output. So this is the baby which I have been showing several times, that baby presented with acidosis, delayed capillary filling, significant hypocalcemia producing seizures, and the postgraduate in one of the center who diagnosed as discharge syndrome, and this baby had a type B aortic arch interruption. A neonate presenting with the cyanosis, looking very blue but peaceful. There is no respiratory distress. In the beginning of transposition of great vessel, there will be cyanosis, but babies will be quite stable. So that is actually dangerous. Whenever there is a severe cyanosis and clinically no murmur, don't believe that it is going to be dangerous. That can be TGA. They can crash anytime. So this is one of the baby with the TGA where respiratory distress is not present in the beginning. So I will skip off this, but what I want to tell you is oligemia X-ray is going to be useful. I will just skip off. I kept that one. So whereas heart failure patients will have bounding pulse in case of vena of Galen or hepatic AVM situation, and they will have massive cardiomegaly. Either it can be abstinence anomaly or any other AV wall regurgitation or ventricular dilations or ventricular dysfunction can have a significant cardiomegaly. So how to recognize heart disease in neonates? There won't be any history, no obvious clinical findings, unreliable auscultation because of tachycardia, lung problem, variable presentation due to variety of natural histories of different diseases. The first presentation may be the last. You will not have subsequent time to diagnose. Okay, let's say diagnose tomorrow. You will not get that time. So these are all subtle indirect clues you have to depend on. My colleague probably will tell that. Physical examination, tachycardia, bradycardia, blood pressure, hypothermia, weak pulse, inspiratory strider, asymmetrical movement of the chest, unlabored breathing, like this unlabored breathing, grunting. You can see the grunting here. Grunting is a physiological means of PEEP. Whenever you keep PEEP, you reduce the alveolar edema. Here also, baby is adapting to PEEP, means they have either interstitial edema or pulmonary edema due to ventricular dysfunction or left ventricular outflow tract obstruction. That's how you diagnose that this is the child with critical aortic stenosis with grunting, suggestive of a physiological adaptation towards that condition. Clinical appearance of syndromic features like a discharge syndrome, presence of seizures, and other Down syndrome, other things will give definite important clues. So these are some of the parameters where you have jaundice and cyanosis here. You have dark baby with the cyanosis. You have a baby with some kind of mottling and edema. All these are important clinical clues. The other subtle clues you get from pulse oximeter, plethysmography, blood gas, X-ray, ECG, and finally echocardiogram will give important. So saturation and pulse oximeter are very important. Plethysmography, I'll just show only this one. Plethysmography, you should see a ascending limb and a definitive good descending limb. You have a sinusoidal waveform here, whereas in case of a coarctation of aorta, you will see the blunted and delayed descending limb in case of pulse oximetry waveform. Of course, you have to look into the errors like motion, perfusion, ambient light. All these things are very important when you are interrupting these kind of things. This is the baby with respiratory distress, heart failure, and mild cyanosis, and the baby presented with heart failure. When we saw that there is a mild cyanosis, it's actually case of a truncus arteriosus after evaluation, because there is a bounding pulse and ejection click in the presence of mild cyanosis, usually suggestive of it's a truncus arteriosus or any of the conditions with aortic runoff situation and admixture lesion. Respiratory distress manifesting as a tachypnea, and usually hepatomegaly will be late. Volume overload due to left to right shunt will cause a tachypnea. Obstruction to the left ventricle will cause the grunting kind of respiration and myocardial disease. These are the important things which we should think about it. Any kind of pulmonary edema, usually it is suggestive of a ventricular dysfunction or outflow obstruction. Any kind of plethora, usually suggestive of it is increased pulmonary blood flow, but later part of the increased pulmonary blood flow can have both increased pulmonary vascularity and also some kind of increased pulmonary venous hypertension. Both will be there in case of later conditions of that. Presentation with severe metabolic acidosis, most of the times it is due to left ventricular outflow tract obstruction. We all should consider that. Various stages of pulmonary edema, we can classify that. It's a more of a theoretical. I'm not going to discuss that. When you examine pericardium, it can be quite pericardium in case of pulmonary atresia, reduced pulmonary conditions, whereas active in case of increased pulmonary blood flow or heart failure due to any other cause. Second heart sound is single in case of pulmonary atresia, critical pulmonary stenosis, or aortic atresia conditions. Single loud in case of a transposition because the aorta is the anterior, and also some of the complex congenital heart disease with the malposed great vessel. A loud pulmonary component. These are all going to be very difficult in the beginning to examine because the babies are having a high heart rate, and you should really examine it when you don't have available data. So the most important thing most of the times you appreciate is ejection click. In a neonate, if you find an ejection click in the presence of mild cyanosis, it's nothing but a truncus arteriosus. Look for the bounding pulse. Ejection click with no cyanosis, usually it will be aortic stenosis. If you find the ejection click at the apex, if you find the ejection click at the pulmonary area, usually it is a pulmonary stenosis. Usually critical pulmonary stenosis, the mobility will be less. You don't appreciate it that greatly like aortic stenosis. Ejection systolic murmurs due to outflow tract obstructions, pansystolic murmurs due to AV wall regurgitation in neonate, or later part of the age group, it's a ventricular septal defect. Diastolic murmurs are rare. If it is present, it's almost always pathological in case of young infants. To and from murmur suggestive of absent pulmonary wall syndrome, whereas continuous murmur, if it is cyanosis with the faint continuous murmur, it's a dangerous condition. You have to consider as ductal-dependent pulmonary circulation. 1 or 2 cases, I'm going to close this. 12 hours term baby presenting with shock, resuscitated, and presenting like shock. Here you can see the critical obstructed infradiaphragmatic TAPVR. Just showing, but my colleagues will discuss more. So here, unusual presentation, disproportionate shunt. Another baby, 2.7 kilogram, referred as a TAPVR, but the child was having severe cyanosis. A TAPVR generally will not have severe cyanosis and pericardium will be active. In this baby, pericardium was very subtle, quite a pericardium, but a severe cyanosis. So TAPVR is unlikely. That turned out to be hypoplastic right heart syndrome. So a baby presenting preterm with a shock after discharge from the perinatology unit and reduced urine output. This is typical history of any of the coarctation of aorta. Any baby which is discharged from the neonatal period, coming back with a shock, you can guarantee that it is an outflow tract obstruction, coarctation of aorta. So you have to get immediate echocardiogram. Don't label it as sepsis. So first you consider treatable condition, then you label it as sepsis. So this is the baby. That one you can see the plethysmography here. It is a very, very not really seen because of the low cardiac output. Perfusion is very less. They will have gallop, low perfusion, and active pericardium. So once you start prostaglandin, you tend to see the normal plethysmography here. So this is a classical case of a coarctation of aorta presenting immediately after discharge. coming back with that. Sometimes you will see the inspiratory strider like this. This is an inspiratory strider. You can see that. And the baby in NICU represented with respiratory infection and inspiratory strider. Then unusual strider, long, prolonged, even postural changes was present, suggestive of its vascular ring. This baby was having an unusual double aortic arch. Here you can see that.
These are indicative.
So heart failure presentation, again we'll have bounding pulse. Cardiomegaly is a mandatory in most of the babies with the heart failure due to systemic fistulas. Cardiomegaly will be there. Respiratory distress will be there. This is a very rare case. We published it recently in Cardiology Young, an umbilical AV fistula, umbilical AV malformation here causing high output failure. We had to close from the right axillary approach. So I will not go into that. To summarize that, subtle clinical clues are very important to arrive to diagnosis. Re-examination or requesting for the echocardiogram is important. Understanding the natural history by all people, neonatologists, perinatologists, and observing the neonate periodically in the hospital, and whenever there is a doubt, calling back the baby from home are going to be useful. And clues from X-ray, ECG, and ABG are going to be very essential to diagnose that. Thank you very much for your attention.
Thank you, sir. Please conduct the proceedings, sir. Dr. Nageshwara, sir.
I request Dr. Kavita Chintala, you can share your screen. She is going to give important information, clues from the X-ray, ECG, and available blood gas data to diagnose the critical congenital heart disease in the young. Can you please share?
Yeah, I thank everyone for giving me this opportunity, especially Dr. Bhaskar and Dr. RSV and Dr. Nageshwara for conducting this symposium. Give me 1 minute to share. Sorry, I'm having some trouble sharing. I can't locate my file. Give me just 2 minutes.
Yeah. So while loading the slides, any questions are there from the other co-faculty or panelists or Subramaniam sir or Dr. Bhaskar, whoever is there? There are some 50 people are in the Zoom platform, remaining are in the YouTube. Can you chart any questions in the chat box? Let me see. So it's all welcome messages. But however, I want to actually emphasize that any disproportionate symptoms in neonate, I think we have to rule out cardiac disease. Now, I think over the period of time, the congenital heart disease pickup rate and diagnosis in the periphery itself has been increased. Probably all this clinical evaluation, X-ray, and echocardiogram is available in most of the centers now, giving the important information. I think you just shared your slides and then disappeared again.
No, that was not my slides. Somehow I can't see the desktop in this sharing panel.
No, you open your PPT and first you open your PPT.
Okay.
Now you open share screen.
Yes.
Can
see,
you
I'm not seeing that it's open, but I can't see the desktop in this window that opens on share.
I request organizers, can you help?
Dr. RSV or Dr. Kavita, can you mail it to one of us? so that we will be
Yeah,
present.
sure.
Yeah.
But it must be a big file.
RSV, can you?
Sir,
Okay.
madam has to share.
Yeah, I'll do.
Madam, if you can share the presentation on email, I'll ask the person to share it from his end.
But that is
You can share it to iaptcb@gmail.com.
No, it looks it's a big folder.
Yeah.
Big folder. Is there any mechanism to help us?
Well, if the next presenter is ready, if the next presenter, Dr. Bhargavi, is ready, then we can go ahead.
Bhargavi, are you ready?
Yes, sir, I'm ready.
So,
Okay.
RSV, can you tell me that email ID again? IAP?
Yes, ma'am. I'm just typing it in the chat box, iaptcb@gmail.com.
Okay. Meanwhile, I request Dr. Bhargavi to share her slides. Can you share the screen, Bhargavi? Can
Yes,
you
sir.
share? Is share option is available to you?
Yes.
Yeah. Okay, that's great. So Dr. Bhargavi is a pediatric cardiologist. Did DNB pediatrics from Rainbow Children Hospital, and subsequently she did DNB pediatric cardiology, and she has been working with us at Rainbow Heart Institute for the past 4 years. Dr. Bhargavi is interested very much in clinical pediatric cardiology and cardiac genetics and fetal echocardiogram apart from routine interventions. I welcome Bhargavi and request you to present your role of echo in diagnosing congenital heart disease from the functional echo point of view.
Good morning, sir. Good morning, everyone. I thank this opportunity, Bhaskar sir, Nageshwara sir, and IAP Twin Cities. Today, I'm talking about the role of echo in diagnosis and management of CHDs. So as we know, like prevalence of CHD is about 8 to 12 per 1,000 live births, and main 10% of the infant mortality rate in India is due to CHD. So mainly the clinical suspicion. The clinical suspicion makes the diagnosis, and the echo is a confirmatory tool. It's not the total diagnostic tool. Clinical, X-ray, ECG, and then comes the echo. When we are doing echo also, we should understand the physiology, normal transitional physiology, as sir has explained, and the natural history of the diseases. So in the echo, what are the indications in ICU setup or in a neonatology setup? What are the indications? If a child had birth asphyxia, if the child is having CDH, PPHN causes are there, child presented in hypotension, shock, and hemodynamically, you are suspecting a hemodynamically significant PDA with NEC and flow reversal, and suspected of CHDs, effusion when there are central lines, and also during ECMO. So mainly the echo is also used not only in structural diagnosis, mainly in the functional and the fluid balance and managing the hemodynamics in the ICUs. So coming for the echocardiography, first we should understand the views. Main views are the subcostal views, apical views, left parasternal views in second, third space, and the suprasternal views. So when we take a clock, if we see a clock in the subcostal area, if we keep the probe indicator at 3 o'clock position and we are turning to 6 o'clock position, then we can assess the interatrial septum. So interatrial septum, in this view, we have to see the IVC and also the flap of the interatrial communication. So it shows the SVC flows, IVC flows, and the atrias, both the atrias. And in the apical four chamber view, it is at the 3 o'clock position where you can see the 4 chambers of the heart, and any chamber disparity is there is to be assessed in that. Next is when we place our indicator of the probe around the right shoulder, like 10 o'clock position in the clock, then we get a parasternal long axis view, and the same position a bit high up towards the left shoulder or 2 o'clock, we can get the short axis views. So the other main important views we have to understand in echo are the Crab's view. These are the suprasternal view, where the Crab's view is like we can see the 4 legs of the crab that are the pulmonary veins that are draining into the left atrium, and the ductal view for the PDA and the arch view. These are the important views which we have to understand in echocardiography. So what are the challenges? So while doing an echo in an NICU from a preterm of 28-weeker to which is on HFO, everything is a challenge there. So in a neonate, we have to understand what is the size of the baby. Is it 800 gram, 1 kg, 2.4 or 3 kg baby, term or preterm? And windows will be very poor when there is a lung involvement, HMD, and there is a minute-to-minute variation of the hemodynamics. Sometimes we get a call that the saturations are dropping or child is stable. When we go there, there will be different hemodynamics. And also the ventilation. Conventional ventilation is different, and doing echo on a HFO, high frequency ventilation, when the trigger is more, then it is a difficult part. And the inotropes also. So these are the challenges from a neonate point of view. So what the operator should have? Operator should have the knowledge, what is fetal circulation, how it is transition phase, what is the transition phase, and we have to know about the lung physiology also, HMD, what is happening, and can we correlate with the congenital, what is there, and how much the PAH is there, and interpretation of the complete data by the operator is very important, and mainly the communication. Communication means the treating physician to the echocardiographer and the cardiologist, we should have a communication so that we'll understand what are the changes happening in a neonate and how we can report it properly. And mechanical factors like machine related factors, quality of the machine. Sometimes we don't get this S12 neonatal probe where we are doing in a very small neonate like 1 kg neonate, doing it a higher pediatric probe will give a difference, and the electrical interference will also be there. So these are all the challenges when we are doing an echo and picking up a subtle changes and high degree of suspicion and repeating the echo. There is no issues in redoing the echo or asking your colleague to have once to look up the echo is nothing is the problem in that. So how it is useful? To echo is useful to understand the hemodynamics like PA pressure, what are the pressure gradients, what is the ventricular function, what is the left ventricle, right ventricle, how can we assess the IVC, can we give fluid more or we should stop the inotropic support, and the last is to diagnose the congenital heart defects. So now I'm showing the cases. It is the case one. Actually today morning call this one. It's a day 2 of life. Saturations are 88 to 90% at FiO2 of 25% on CPAP. So child is having mild distress, and this is the echo. When we are doing this echo, we should focus, here is the foramen flap. How is the foramen flap? Is it bulging more towards right atrium or more towards the left atrium or almost in the midline? This is mildly towards RA. And here in the first panel, we are seeing there is a blue flow coming from here, my arrow mark. This is the ductus venosus flow, which is normal in the transitional phase. So this is the DV. So this is the hepatic vein. This is the ductus venosus, which is yet to close, and this is the IVC. And we are also seeing the ductus, which is predominantly left to right. So this is like a normal transitional circulation phase echo, where the fetus is transforming to neonatal circulation. You have a drop in PVR, increase in SVR due to your placental cut down, and there are closure of shunts like ductus venosus is still there and yet to close, and everything is going to increase pulmonary blood flow. So this is a transitional circulation where there is a neonatal PVR. There is no significant PPHN to give sildenafil in this condition. So it takes another 36 hours to settle. So it is a term baby, but in preterms, what will happen? There is a different scenario where there is an immature myocardium, more acidosis can happen in the preterm, and we should be more careful in doing a preterm echo and in concluding the diagnosis, because transition phase is not very smooth in the preterms. So this is a second echo where this is another neonate where the saturation of 70%. So we can see PFO is this is the intraatrial communication, which is completely right to left shunt. And here in this, we are seeing a 4-chamber view where there is a dilated and dysfunctional right ventricle, and the septum IVS is pushing towards the left, causing squeezed left ventricle, and the color Doppler is showing the severe TR. So when we assessing color Doppler, so my indicator is my arrow down. So whatever the flow towards the indicator will be red, away from the indicator will be the blue. So blood flow should be there from the right atrium to right ventricle. So it should be red, but it is a regurgitation. That is the blue flow causing tricuspid valve regurgitation. And this is the RV systolic pressures, which is 90. It is very high, suprasystemic RV pressures. That is the reason you are having right to left shunt across the intraatrial communication. And this small shadow is the descending aorta. I will again talk about this one. So this is a case where we can note there is no intracardiac shunts and child's lungs are pretty bad. And this is a PPHN condition. So as we know, when there is an increased PVR, like PVR, there will be right ventricular afterload will be increased and there will be right ventricular hypertrophy. That hypertrophy again causes RV dysfunction, dilatation of the RV, and again compressing the LV and decreased preload to the LV and causes LV dysfunction. These all as a circle, we cause a low cardiac output and desaturation. So this is about the PPHN. So how do you estimate the TR? When you are doing an echo, we should understand how we are estimating the TR gradient. So what we do is we should keep a Doppler, continuous wave Doppler across the tricuspid valve regurgitation, and we should Doppler the waveform. This is the waveform. So when we are taking the peak of the waveform max, so 4 into the velocity max of the TR max will give the right ventricular pressure. And then we should add the RA pressures. RA pressures means you have to assess your IVC. If your IVC is collapsing, you can add 5. If your IVC is like just 50% collapsing, add 10. If it is not collapsing, add 15 to that 4 into V square. So that gives our pulmonary arterial pressure. But when assessing the TR, there will be many difficulties. Like in this echo, I am showing there is an eccentric TR. So the TR jet is going and touching the IAS and going eccentrically. Here you cannot get as a complete waveform. So we'll get an incomplete trace. This incomplete trace, there will be difficulty to measure how much is the PA pressure. Then we should understand how is your intraatrial septum and IVS, are they going towards the right side? So here in this video, still we can see that IVS, it is like shuttering. It is going to left and coming back. It is going towards the left side. So is it like that? And how are your pulmonary arteries? These things, PFO shunt, PDA shunt will give a clue. Is it a severe PAH or not? So sometimes we have we'll have a neonate, like this is a 20 days old neonate, came with saturations of 80 to 85%, and respiratory distress is severe and we have to ventilate this child. So here also we are seeing the 4-chamber view where the right heart is completely enlarged and there is a severe tricuspid regurgitation. And also here we are seeing one chamber is there here. So this is the first echo I have shown that that circle is a descending aorta and here there is a chamber. And when we saw the intraatrial septum also, it is completely right to left shunt. So you have a PAH picture with complete right to left shunt of the at intraatrial septum communication and having a chamber between the left atrium and the descending aorta. This should be a clue for our TAPVC. So for TAPVC to diagnose, even a 4-chamber view is very important to see that chamber. So here in the first panel, this is a vertical vein, left vertical vein going like this and meeting the innominate vein and coming towards the dilated SVC. We call it as that in the figure of 8, this is the first part of the 8. So from the pulmonary veins joining to form the vertical vein going to innominate vein and the right SVC. So this is a supracardiac TAPVC with left vertical vein and joining the innominator. So this echo is also the supracardiac TAPVC of left vertical vein, but there is so much turbulence, which we are not seeing here. This turbulence is the obstruction at the vertical vein level. So this is again same, but it is a right, it is here it is going, this vertical vein is going to right and joining the SVC. And here again, it is an infracardiac TAPVC where the vein is coming and joining into the portal sinus. So there can be supracardiac, cardiac, infracardiac or mixed TAPVC, but for the clinician point of view, clue should be the chamber. In a 4-chamber view, when we are doing an echo, if you see a large chamber behind the LA, any chamber behind the LA other than your descending aorta, you should suspect there should be TAPVC. And see, it will be like in a schematic diagram, this is the LA, this is the chamber, and this is the descending aorta. This, the down picture, just I kept to show the normal pulmonary veins, how you can see in a 4-chamber view. So my pointer that red is coming is the pulmonary vein. So in 4-chamber view also, at least one pulmonary vein you can assess in 4-chamber view in a normal heart. But in a TAPVC heart, you cannot see, like nothing is coming to the LA roof, and there will be a chamber. That should give a clue to us to suspect TAPVC rather than a PPHN in that point of view. So when you're coming to intraatrial shunting, so if it is a right to left shunt at the intraatrial communication, first diagnosis, we should keep still the PPHN, but should never miss like a TAPVC, seeing the chamber confluence behind the LA, and sometimes the critical PS and hypoplastic right heart syndrome like pulmonary atresia intact IVS. These will also have the right to left shunting at the intraatrial communication, but the major clues comes from the X-ray where there will be oligemia and cardiomegaly, and coarctation of aorta. Mainly it involves the right heart. So this also causes right heart dilatation and it gives like a PAH. The shunt of the IAS right to left, we should understand it can be TAPVC also many times, but clearly we have to see. If you have the same shunt at the left, IAS left to right with CHF, so that mainly it will be involving the left heart like mitral valve anomalies, LVOTO, or large extracardiac AV malformation in a neonate like Sir has shown, umbilical AV malformation or hepatic vein of Galen. That causes volume overload to the left heart and then heart failure, and sometimes PH also it will be there. So when you see in a neonatal echo, normal intraatrial communication with no excessive flows, then you should mainly think about transitional circulation. Give at least 1 or 2 days and child will be better. So again, now coming to the ventricular chambers. If you are seeing the ventricular chambers and IVS, so this is a case of 5-month-old child who had only one episode of respiratory tract infection and never had any murmur. Pediatricians was auscultating, but at the 4th month only they suspected murmur. This is because when you have a ventricular septum and due to because your PVR, pulmonary vascular resistance will fall very slow, we should be very careful in auscultating, because when the PVR falls completely only we can hear the murmur. Sometimes we may hear like 2/6 murmur, but in our busy days we may miss it, but we should be very careful. Any child, any neonate, if you're suspecting any murmur, small murmur, short murmur also, it's better to evaluate in the echo to know about the ventricular septal defects. So another child, we can discuss, it's a 20 days old child, neonate with heart failure and severe PAH. It was reported outside that there is a small VST, we can see in the 3rd panel, which is right to left shunt, and severe PAH. Lungs are improving. So here, mainly the clinician had a doubt because there is a small VST and severe PAH. How to correlate both that? Because it's not a large post-tricuspid shunt to give PAH, and lungs are also improving, but child is still on venti. Then what we have to assess is we should see other than intracardiac, so the area behind the heart. When we are assessing the aorta, we saw a large aortopulmonary collaterals. So when you have the subtle clue in this is the small VST or moderate VST, but child presenting with congestive heart failure. So that time you should think of any extracardiac shunts or any AV malformations or collaterals we should think. It is this panel also same, the heart failure, child presented with heart failure, and we can see this is an SVC flow, which is high SVC flow. And when we have suspected, when we thought of doing on the AV Fontanella probe, when we kept the probe, we saw a vein of Galen malformation. So whenever you have a heart failure children, if we report heart is normal also, we should understand some other thing is there. It can be hepatic AV malformation, vein of Callan, or large aortopulmonary collaterals. So doing a second time echo and rediscussing will not give any problem. It will give a diagnosis. So in the volume overload conditions, when you are seeing heart, we should see how the pulmonary veins are there. Is it LA, how it is? And intraatrial septum, is it bulging more towards left atrium means RA pressure is more towards right atrium means your left atrial pressures are more and post tricuspid shunt is more. So any disproportionate flows that we most of the time see is in TAPVCs also, and increase in the flows. So these
How
are
many
the
more slides, Bhargavi?
10 sir, over.
10
So
slides more?
I'm going fast.
Okay.
So this is a child with neonate with severe pulmonary stenosis, but you have a very less gradient. This is due to the neonatal PVR that is causing the less gradient. But when we see the jet, it is very critically narrowed. So we can underestimate. And next is the ventricular dysfunction part. We should be very critical when we have seen ventricular dysfunction in child in shock. We should suspect the outflow tract lesions. So when you are assessing the ventricular function, the theme is to M mode will give only the fractional shortening. It depends on the diameters, diastolic and systolic by diastolic. And the Simpsons or volumetric methods will give the ejection fraction. So there is another method of cardiac output where we calculate from the LVOT area and the velocity time integral. So when we are coming to PDA, we should understand the PDA flow patterns. What is there any, what is the LA aorta ratio, reversal in the descending aorta, and size of the duct, and also mainly the clinical hemodynamics. So these are the patterns in the PDA. If you have completely the below tracing, this is the right to left and this is a sicker infant. But if you have both left to right and the right to left, this is common where we see a growing pattern of the PDA. And this only left to right shunt and this high velocities we will see in a closing PDA. So the major risky one is the right to left completely shunt. So this is the large PDA where we can assess in the ductal view. When we are assessing the PDA, we should see the descending aorta Doppler also, where there is a diastolic reversal in the descending aorta. So coming to the another one is a fluid assessment. We should understand how the ventricles here, the kissing ventricles means systolic and diastolic are very close, and the caliber of the IVC we should assess, and the collapsibility index and distensibility index. So collapsibility index is the maximum diameter by minimum diameter by mean. But when in a ventilated child, we cannot do that. We should do a distensibility index. But those are all for a pediatric adolescent and to adults, not for the mainly neonate. We should see the size of the IVC. So echo is also important when you're assessing a pericardial effusion, tamponade features when you're suspecting. And when you are using central lines, if you have a neonate with sepsis, long-standing infection, we should assess any thrombus is there. Here is we are seeing a large thrombus attached to the lines at the IVC level into the RA. So another important feature of thing is in assessing ECMO, where we keep the cannulas in aorta and the venous and arterial cannulas to see the flow across the cannula and how is the perfusion. So this is I'm concluding. The echocardiographer, we should correlate the clinical and the echo findings both to reach the diagnostics. We need of subtle clues to be considered. Repeating the echo is no problem, and we should understand the hemodynamics well. Thank you.
Thank you very much. I think we'll take questions at the end. May I request Dr. Kavita to share her screen, or somebody who is doing?
Yeah, I sent my... Can somebody from IAP share it?
Dr. Kavita, you sent to IAP TCB
Yes,
Gmail.
sir. Yes, sir. And Dr. RSV said they got it and they'll be able to show it.
Okay. Mr. Ayan, are you available? Ayan?
Yes, sir. I am sharing the screen, sir.
Yeah.
So Dr. Kavita Chintala is a senior pediatric cardiologist. She did her pediatric cardiology training program in USA. and she has been practicing as a pediatric cardiologist at Apollo Children's Heart Institute, Hyderabad, Jubilee Hills, Hyderabad. She is going to give a talk on clues from the X-ray, ECG, and available blood gas in diagnosing critical congenital heart disease in the young.
Thank you, Dr. Nageswara Rao. Thank you, Dr. Bhaskar, Dr. RSV, all the members of the Iaptcb for giving me this opportunity. Can we make the slides bigger? No. Okay, it's okay. Yeah, next slide, please. So I've been asked to talk about clues from the X-ray, ABG, and ECG for critical congenital heart diseases. So this is, we cannot cover all congenital heart diseases in this talk. And since the topic is about critical, I'll restrict myself to that. So by definition, critical congenital heart diseases are those that are life-threatening, and they cause either death or require an intervention in form of surgery or catheter intervention the first 4 weeks of life. So these are what come under critical congenital heart diseases. So mostly we are focusing on the neonatal aspects. They have a high mortality rate, as you would imagine, accounting for about 3 to 7.5% of infant deaths. Now, why is it important that we make a diagnosis promptly is for the same reason, because of the high mortality. They can also cause acute collapse, as Dr. Kianar was discussing in some of the patients. And also they are known to have a worse surgical outcome and a neurodevelopmental outcome if they are diagnosed late. This Kaplan-Meier survival curve on the right shows that there's better survival if the diagnosis is pre-discharge or antenatally done, which is the blue line, and a worse outcome when it is done post-discharge. So it's very important that we do not miss, we do not send any baby without diagnosing the congenital heart disease. Next slide, please. So again, there are several congenital heart defects, and I know for a pediatrician, the varieties of congenital heart disease may be overwhelming to understand, but we will again focus more on the 7 main critical congenital heart diseases that are also the target for our pulse oximetry studies. So the hypoplastic left heart syndrome and its associated conditions like, critical aortic stenosis, coarctation, all these come under the hypoplastic obstructive left heart types. Then pulmonary atresia, which I want to also include the single ventricles, which have a decreased pulmonary blood flow, like pulmonary stenosis and pulmonary atresia. Then we have our 5 T's, which are tetralogy, TAPVC, transposition, tricuspid atresia, and truncus. So we will be focusing on these. Next slide, please. So coming to the first investigation after a physical examination we do is chest X-ray. And this slide here shows that the right heart border is formed by the superior vena cava, the right atrium, and the inferior vena cava, whereas the left heart border is formed by the aortic root, pulmonary trunk, left atrium, left ventricle. So we have to understand, what a basic chest X-ray, a frontal view of the cardiac borders. And so we will be able to analyze this further. Next slide. So in the chest X-ray, I think is a very important component of assessment of any congenital heart disease. Of late, echo is always available, so we jump onto the echo, but I think there's a lot of learning points to be gotten from chest X-ray. So when you're looking at the X-ray, we look at the size and shape of the heart, the pulmonary vasculature, which is very important, and I'll be discussing that. Also look at the airway and mediastinal shadows, what is the situs of this patient, and look at any bony abnormalities. A formal, discussion of chest X is not possible, so I'll be giving a few case examples to see what is important to review. Next slide, please. So first look at the cardiac size. So this slide represents how we measure the cardiac size. So you draw a midline through the sternum and take the maximal right heart border. My pointer is not visible, right?
Not visible.
Yeah. So I'm sorry because I'm not sharing. So the MRD is the maximal right-sided diameter, and the left is MLD is the maximum left-sided diameter. So you have to take the maximal diameters on either side of the spine and then measure the thorax from the lateral borders of the last ribs. And then this ratio between the two will give you the cardiothoracic ratio, which normally should be 50%. In an infant, it can be a little bit more, 50 to 60% is accepted. Can you click, please? Yeah, so what about this slide on the right? Is that a correct way of measuring cardiothoracic ratio? I see many times this is how it's measured. So they just draw a line, at so-called maximal points of the heart and then the thorax. But you always should remember that the maximal point on the right side of the border and the left side of the border may be at different places. So the left panel that I'm showing is the correct way of assessing cardiothoracic ratio and not the right-sided panel. So that's an incorrect way. Next slide, please. So again, focusing on the critical congenital heart disease in the newborns, I think the most dramatic cardiomegaly that we see when you see something like this on an X-ray, the middle X-ray that I'm showing, the first X-ray on the left side, it's a massive cardiomegaly, almost like a globular or a box-shaped cardiomegaly. And sometimes you also see a wall-to-wall heart. And when you see something like this, there aren't very many conditions that cause such a severe cardiomegaly in the newborn period. And you should keep Epstein's anomaly in your mind for something like this. And the second one would be an atrioventricular septal defect. The reason is, if you notice, the right heart border is very prominent in that first X-ray. And that is accounted by a huge right atrium. And this can happen in Epstein's anomaly, as you all know, because of the associated atrialization of the ventricle, and also can happen in an atrioventricular septal defect that is associated with severe AV valve regurgitation. So this is right atrial enlargement. Then the other conditions that cause cardiomegaly can be a truncus, which is increased pulmonary blood flow in a cyanotic condition. It can have bilateral or biventricular hypertrophy. TGA also does not cause such a dramatic cardiomegaly, but does cause some cardiomegaly, and some types of TAPVC can cause cardiomegaly, mostly due to right ventricular hypertrophies. Then if you have severe tricuspid regurgitation, any of the single ventricles or pulmonary atresia intact ventricular septum, you can again have a right atrial dilatation and cardiomegaly. So the middle X-ray depicts a child from with Epstein's anomaly, and then the second X-ray on the right is one with an AV canal defect with severe AV valve regurgitation. Now, differentiation can be seen in Epstein's anomaly. Usually, the pulmonary trunk is not prominent because they may be associated with decreased pulmonary blood flow. And in the right panel, you can see a prominent pulmonary bay, which is because of the pulmonary hypertension associated with the AV canal. Next slide. And how about, then there are some characteristics cardiac shapes, as you all must have read, that can account for some, clues to diagnosis. So this X-ray shows a typical, what we call a boot-shaped heart. And you must all be familiar with the condition that is Tetralogy of Fallow. So this is caused by a prominent, point of the boot is towards the left side. It is due to the associated right ventricular hypertrophy that tilts the heart into that direction. And then it's also associated with oligemia. If you can see, the pulmonary fields are showing oligemia. So this is characteristic of tetralogy. But I must say that these are very, textbook type of X-rays, textbook type of pictures. But we may often have a normal X-ray also, a normal shaped heart also on tetralogy. So it is not always that we see something so characteristic. So we have to put multiple clinical features into account before diagnosing a congenital heart defect. Next slide. This one, this X-ray shows, can you not press on the slide so soon? This one shows a typical egg-on-end appearance of a classical presentation, again, of a transposition of great arteries. This is because the appearance is because of the narrow pedicle in the mediastinum because of the altered position of the aorta and pulmonary artery. Now, normally, the mediastinum is formed both by the aorta and the pulmonary artery, so they're a little wider. In this, the relationship of aorta and PA is more anterior-posterior, so the pedicle becomes narrow, and then there is cardiomegaly, and this accounts for this appearance of egg-on-end appearance. Next slide. This X-ray, we've already touched upon this. So this again shows a very prominent cardiomegaly. Both the right heart and the left heart borders are enlarged. And then the pedicle is also a little narrow. And the lung fields, if you look at, is oligemic lung fields. And this is typically, next slide. This is typically explained as the box-shaped heart of the Epstein's anomaly, which I was discussing. Next slide. How about this one? This X-ray, if you notice, there is a little cardiomegaly, not such a prominent right heart border. The mediastinum, if you look at it, the pedicle of the heart is prominent, and there is widening of the mediastinum. Next slide. Again, that's something we see typically, and then pay attention to the pulmonary vascular fields. We'll also come back to this. So this X-ray, the one I just projected is again, a textbook picture of what we call a snowman appearance or a figure of 8 appearance. This is very characteristic of TAPVC type 1, which is supracardiac TAPVC. We see this X-ray, but the left one is a real patient, so it may not be as dramatic as that shown in the middle panel. So the head of the snowman is formed by the ascending vertical vein, which you see on the left side of the sternal border, and then it goes into the innominate vein, and the innominate vein drains into the superior vena cava, which is also prominent, which you're seeing on the right side of the spine. I'm sorry, I'm not able to point it out. But so the prominence on the left side of the sternum in the upper half is the ascending vertical vein, which drains into the innominate vein, which connects to the superior vena cava. So you have a dilated superior vena cava that is on the right side of the spine. Next slide. How about this? Then after looking at the cardiac borders and cardiac size and shape, look at the mediastinum, which is, what you want to call the pedicle of the heart or the root of the heart. This X-ray shows a prominent aortic knuckle. So it's a very prominently bulging out on the left side of the sternum. Then next slide. And how about this? Anybody wants to take a guess? I don't think they are allowed to talk, right, sir?
But they can type in chat box.
Yeah. Anybody wants to guess what this is?
They can type in chat box, please.
So looking at the pedicle or the mediastinal portion of the heart, you can see that the aortic knuckle, which is supposed to be on the left side of the sternum, is missing. And yes, somebody said the right thing. And you can see that the knuckle of the aorta is on the right side of the spine. So this is a right-sided aortic arch. So this gives clues to presence of associated congenital heart anomalies. Next slide. So you have an enlarged, so the aortic knuckle can be enlarged in coarctation, which is related to a post-stenotic dilatation. So when you have coarctation, the area beyond the coarctation will dilate, and it causes a prominent bulge in the aortic knuckle. Truncus arteriosus also, because the trunk is a big structure from which the pulmonary arteries come. The trunk is typically big, and that can cause an enlarged aortic knob. And in tetralogy also, we know that the right ventricular outflow tract is small, and in proportion to that, the aorta is large. So there is a prominent aorta in all of these Tetralogy of Fallow patients, and that can give a prominent aortic left-sided shadow. And the aortic knuckle is small or not at all seen in hypoplastic left heart syndrome because it is associated with varying degrees of hypoplasia of the ascending aorta. Then, as I was pointing out, picking up a right-sided arch is very important because in association with all other findings, you can come to a reasonable conclusion of it happening in 25% of patients in Tetralogy of Fallow, and a higher degree, about 40% of patients with truncus can have a right aortic arch. Now, how do you differentiate between the two of these based on X-ray? So if you have a right arch with pulmonary oligemia, likely to be tetralogy, and if you have a right arch with pulmonary plethora, it is likely to be truncus because the latter is an increased pulmonary blood flow condition and the former is a decreased pulmonary blood flow condition. So this is how some of the clues you can put together about, you have already examined a baby, you know whether the baby is cyanotic, you know whether the baby is in heart failure. And then if you combine this X-ray findings of pulmonary vasculature and the shape of the heart and the size of the heart, you can reasonably come to a diagnostic conclusion. Next slide. This X-ray here, again, if you pay attention to where the aorta is supposed to be, there is two little bumps on the left side of the trachea. And then on the lateral film that you're seeing below, it is actually a barium swallow. I'm sorry, it's not a very clear picture, but in a barium swallow, that's also showing two indentations. Anybody wants to guess what this is? Next slide. So this one, the frontal view shows those two indentations, which we call it a figure of three appearance. And this is a characteristic finding of coarctation of aorta. So the indentation is a coarctation, and then there is a post-aortic dilatation that gives this appearance. And the corresponding picture on the barium enema gives a reversed 3 sign because of how the barium is indented by the aortic arch and the post-aortic dilatation. It's a reverse 3 sign. So this is also important pickup for coarctation. Next slide. Now this X-ray shows something prominent on the left heart border, right? So by the location, this is just below the aortic arch. So this prominence is caused by a broad pulmonary trunk or an enlarged pulmonary trunk. Again, a very important finding to assess the pulmonary arteries in critical congenital heart diseases. Next slide. So you can have both a small pulmonary artery and an enlarged pulmonary artery. As shown in this picture, the enlarged pulmonary artery usually can happen in right ventricular outflow tract obstructions like a critical pulmonary stenosis, where you find a post-aortic dilatation. And we all know that pulmonary artery hypertension can cause a prominent main pulmonary artery segment, but it is associated with peripheral pruning, means the pulmonary vessels in the lateral borders of the chest field are dark, whereas the central pulmonary arteries are very prominent in pulmonary artery hypertension. Then you can have a small pulmonary artery along the left heart border caused by your right heart obstructive conditions like tetralogy, pulmonary atresia, where the artery is hypoplastic. In trunkers, you may not see a pulmonary trunk because the pulmonary arteries are coming individually from the aorta. And in a transposition, as we discussed also, you will not have a prominent pulmonary bay because of an abnormal posteriorly located pulmonary artery. So pay attention to the structures that are causing a prominent left heart border. Next slide. Now coming to a very important aspect of interpreting the chest X-ray for congenital heart disease is the pulmonary vascularity. Again, I think of all the tests, if you want to focus on one thing, it should be the pulmonary vascularity, because the size and shape may not always be so specific as we discussed. But pulmonary vascularity gives you a physiologic classification of the congenital heart diseases and also an approach to treatment. So this one X-ray is a normal X-ray that we are looking now, and typically you're seeing the central pulmonary arteries. The one with the prominent pulmonary artery is what we call a right descending pulmonary artery, the one with a little arrow. So what this slide is showing is that a normal pulmonary vasculature means the diameter of the trachea and the diameter of this lower descending pulmonary artery should be equal. Then that is a normal vascularity. Just to give some objective evidence, because even though we are in practice for a long time, sometimes you can look at an X-ray or stare at an X-ray and try to decide whether it is normal or increased pulmonary vascular marking. So sometimes there can be a debate. So this is a little objectifying evidence where the tracheal diameter is equal to the right descending pulmonary artery diameter. Next slide. Now the X-ray we have on the left one shows a more prominently dilated right descending pulmonary artery. And if you look at the tracheal diameter, this diameter is bigger than the tracheal diameter. So this is an X-ray that I would call it as having increased pulmonary vascularity. Next slide. Now this is a zoom of this chest X-ray. And another way of objectifying whether there is pulmonary vascular congestion is when you look at it closely, you can see some end-on bronchioles. So the lower circle in that white is that circular structure is an end-on view of a bronchus. And then the yellow circle above next to that is a pulmonary vascular pulmonary vessel. So look at the sizes. So if the vessel is greater than the end-on view of the bronchus, then there is pulmonary vascular congestion. And typically it is reported that when you see it bigger than the bronchus, the QPQS ratio is more than 2 to 1. That means the pulmonary blood flow is more than twice that of a systemic blood flow, which is considered a significant left to right shunt. So this is an objective way to look at that. And if the vasculature and the bronchus are same diameter, then it is either a normal X-ray or you have a small shunt which is less than 2 to 1. And if your pulmonary arteries are smaller than the adjacent bronchi, then it is a decreased pulmonary vascular condition. Next slide. So this X-ray I'm now projecting, you can see that the pulmonary vessels are less prominent than the trachea in diameter, and then the lungs appear a little dark, the lung fields. So this is an oligemic X-ray. Next slide. So looking at these, so now that you've identified plethora versus oligemia, some of the conditions that give increased pulmonary blood flow, and Dr. Nageshwar already alluded to it, but these are transposition, TAPVC, truncus, all cause plethora, and all of these complex single ventricles that, you may not want to go into details, but anything that has no pulmonary stenosis can cause increased pulmonary vascular markings. And then pulmonary atresia, although we see it as a decreased, as a condition without pulmonary blood flow, but they can have some major aortopulmonary collaterals, and then the X-ray can look as if it is congested. Then oligemic conditions, typically we know are Tetralogy of Fallow, Epstein's anomaly, it behaves more like a functional pulmonary stenosis. Then all of those single ventricles that can be confusing, but they have pulmonary stenosis, can have oligemic lung fields, and then the typical pulmonary atresia will have oligemic lung fields. So these are some of the ones that you have to keep in mind to help you with your diagnosis. Next slide. Next slide, please. Okay, and increased pulmonary vascularity can be of two types. The one that we are discussing with increased pulmonary blood flow, all the congenital heart diseases without restriction to pulmonary blood flow are causing active congestion, the typically shunts. So in this, as we said, vessels are enlarged and they are seen more peripherally than normal. Sometimes they can be tortuous, and then the margins still remain distinct for these dilated vessels. Whereas you can have a condition called passive congestion, which is due to back pressure. Look at it as back pressure from the left heart, where the pulmonary venous pressure is increased, and this causes pulmonary congestion. In this, the pulmonary vascular margins remain indistinct because this is more of an interstitial edema. So the margins of the pulmonary vessels are indistinct, and sometimes they also can cause lines towards the periphery of the lung fields called curly B lines. This is typically seen in your TAPVC, pulmonary vein stenosis, left heart diseases like mitral atresia, Artery. Next slide. So this is the left-sided X-ray. What do you see? You see a little cardiomegaly. The mediastinum is a little prominent, but if you look at the lung fields, it has a very fine reticular pattern, and close-up can reveal, some pattern of the interstitial edema. And in the right one is also similar with a more hazier lung fields and a reticular pattern. So these are typical. The left child is a obstructed TAPVC, which is having elevated pulmonary venous pressure and a typical reticular pattern of the lung. And this can also happen in pulmonary venous obstruction. This right-sided child is hypoplastic left heart with a restrictive atrial septum. So there was no blood egress from the left atrium into the right atrium. So develop pulmonary venous hypertension, and this is developing a reticular pattern. Now these newborns have to be distinguished from your hyaline membrane disease and congenital pneumonia. So putting together all the clinical features is going to help you to distinguish those. Next slide. After looking at the pulmonary vasculature, also look at the situs of the children. So the left panel shows a dextrocardia, and if you look at the abdominal situs, the liver is left-sided and the stomach bubble is on the right side. So this is a dextrocardia with situs inversus, whereas a panel on the right side shows a dextrocardia with a normal situs, normal abdominal situs. So liver is either right-sided or midline liver, but the stomach is left-sided. So what is the concern if you have either patterns is that if you have a dextrocardia with situs inversus, that is rarely accompanied by congenital heart disease. Whereas if you have a dextrocardia that is isolated or with a situs ambiguous or a situs, normal situs, abdominal situs with isolated dextrocardia, they are at risk for congenital heart disease. Almost 90 to 95% of them can have congenital heart disease. So pay attention to this when you're looking at the X-rays. Next slide. Now coming to ECG, I spend more time on the X-ray because ECG is not very rewarding in an accurate diagnosis of congenital heart disease. It can be an ancillary finding because mainly the ECG, helps us with rhythm. Arrhythmias are rare in congenital heart diseases. The age-wise changes in axis happen. So sometimes it is difficult to say whether it's a, axis deviation or hypertrophy. Then some of the changes in ECGs can be non-specific, and then congenital heart disease can have combined defects. So sometimes, the X-ray, the ECG findings may be a little confusing and not very specific for each congenital heart disease. Next slide. I'll just spend a couple slides. It's very important to understand that a newborn has a RV prominence, right? Because of fetal high pulmonary resistance in a fetal life, that is also there in the neonatal period. You have a high resistance pulmonary circulation. So the right ventricle is dominant as shown in this picture where the yellow in the newborn is the thick right ventricle, whereas in adult, yellow right ventricle is very thin. So this manifests on the X-ray as a right axis deviation, right ventricular hypertrophy. So we see large R waves in V1 to V3, and you can have T wave inversions in V1 to V3. Then, of course, we have tachycardia in a newborn. And then right ventricular hypertrophy can be seen as tall R waves in V1 to V3, or also an RSR pattern in V1, or a pure R in V1. And then you can have having some Q waves in inferior and lateral leads is also normal in a newborn. Next slide. So it's important to understand the axis. Just one quick slide because this somewhat helps in understanding congenital heart diseases also. The normal newborn, when it is born, the orange one is the, so from 30 degrees to 180 degrees is the 1 week to 1 month old axis. And then in 1 month to 3 months, it moves more towards the left side. And then as you see with age, the axis is moving left side. So the green one is the adult axis, which is normally from, minus 30 to 90 degrees. So this is the axis. And on an ECG, it's very easy to pick up the axis as I put those ECGs on these sides. So in a normal, so just look at 2 leads. Just look at lead 1 and look at AVF. That's all you have to do. So if it is upright in lead 1 and upright in AVF, it is a normal axis, means beyond the newborn period. It is a normal axis for children and adults. And if you have an upright QRS in lead 1 and a negative QRS in AVF, it is left axis deviation as shown there. And if you have a negative QRS in lead 1 and positive QRS in AVF, it's a right axis deviation. So only look at these 2 leads and decide what the axis of the child is, and then compare with the age of the child to understand whether it is normal or not. Next slide. So this is a normal newborn ECG. So if you look at the lead 1, it's a negative QRS in lead 1 and positive QRS in AVF. So it is a right axis deviation somewhere between 90 and 180 degrees, which is normal for a newborn. And if you look at the R waves in V1 through V6, you see very prominent R wave in V1 and V2 and V3 that indicate right ventricular dominance, which is normal. And also you're seeing upright T waves in V1, which is again normal for 1 week of life. And then in adulthood, after 1 week and up to 7 years, or sometimes even up to adolescence, it can be inverted. So this is a normal newborn ECG. So this is not RVH. It is normal right axis deviation and right ventricular dominance. Next slide. How about this ECG? If you look at QRS in 1, it is upright. But if you're looking at QRS in AVF, it is negative. So this is an example of a left axis deviation. So important to identify left axis deviation because there are not many conditions that cause this. The 2 primary ones that cause left axis deviation, next slide, one is a acyanotic heart disease, which is an atrioventricular septal defect, and the other is a cyanotic heart disease, which is a tricuspid atresia. These are due to shifting of the left bundles because of these defects. So identify left axis, then you'll narrow down your differential diagnosis. Next slide. Now this is a 10-day-old. Anything abnormal here? Look at, there is right axis deviation, which can be normal. There's prominent R waves in V1, which is also normal. But if you look at the T waves, it's a biphasic T wave, and mostly it is an upright T wave in V1, which is abnormal for a 10-day-old. So by 1 week, after 1 week, it should be upright. So this indicates, again, RVH in this neonate. So that's why you should know the normals according to the age. Next slide. Now, some of the criteria for RVH, I think I'll skip this because of time. Next slide.
Dr. Kavita.
Just two more slides.
Okay.
Then, so LVH in general is present for tricuspid atresia and coarctation. RVH conditions, you know, tetralogy and hypoplastic left heart syndrome. And coarctation in infants presents with a right ventricular hypertrophy. Then biventricular hypertrophy can be seen in truncus and TGA. Next slide. Skip this. Yeah. Quick slide on ABG. Next slide. So ABG, I'm not going to spend a lot of time, but we know that how important hyperoxia test is, right? So the hyperoxia test is to differentiate between congenital cyanotic heart diseases and non or pulmonary conditions, which are causing cyanosis. So you do an ABG on room air, and then you repeat the ABG after 10 minutes of administering 100% FiO2. We all know that. So it's a bedside test done I think it's still a very valuable test. I don't see that being performed very often, I think, because of the availability of echocardiography nowadays. But this nevertheless is a very important bedside test that we have an important information from. So normally your PaO2 should be around 70 to 90, and with 100% FiO2 in a normal condition, you expect the PaO2 to go to about 300. Now, if the PaO2 increases to more than 150, then it is likely to be a pulmonary disease rather than a cyanotic congenital heart disease, because usually they remain below 150 for congenital cyanotic heart diseases. Now, there is a little bit of distinction between, the various types of congenital heart diseases, but if you want to go by the rule, less than 150, if it remains less than 150, you have a cyanotic heart disease. Then usually parallel circulation like TGA is probably most cyanotic. So they tend to remain in the 40 to 50 range. And sometimes it can go a little bit higher in mixing conditions like truncus, it can go a little bit higher. Next slide. So sometimes you can have a false negative, meaning a higher than 150 PaO2 in some of the congenital heart diseases when there is a very high pulmonary blood flow, suppose something like truncus. And then sometimes some of the conditions have a preferential streaming that can also give rise to a false negative. Next slide. Then false positive can sometimes be seen where there may be a paradoxic fall in PaO2 because of constriction of PDA or washing out of the alveolar nitrogen. So these are very rare conditions, but in most of the time it's quite diagnostic. Next slide. I'll just skip this one. Also differentiates between acyanotic and cyanotic heart disease. So this is room air. There's quite a bit of overlap between cyanotic and acyanotic heart diseases. Next slide. Whereas if you do a hyperoxia test, you see that the acyanotic are to the left of the panel and the cyanotic are to the left of the panel. So this differentiates very nicely between cyanotic and acyanotic also, the hyperoxia test. Next slide. Whereas if you want to see, it does not differentiate or it does not provide an accurate anatomical diagnosis. So you'll know if it's a cyanotic or acyanotic, but if you look at the various types of cyanotic heart diseases, it may not be very diagnostic. But in general, the least PaO2 we see in transposition of great arteries, whether it is on room air or otherwise, hyperoxia. Next slide. So take home messages, a careful history and thorough physical examination, absolutely, irreplaceable for diagnosis of congenital heart diseases. I will say that chest X-ray has many clues and ECG may have a limited value and ABG is very useful. Next slide. Thank you so much. And I want to say that the chapter you're learning today is going to save someone's life tomorrow. I'm very serious because if you pay close attention to this seminar today, you will probably, save a life and not send somebody with a critical heart disease home. Thank you very much.
Thank you very much, Dr. Kavita. It's a really great elaborative X-ray ECG session. Now, without wasting time, I actually welcome Dr. Professor Jairanganath. He's a Professor HOD of Pediatric Cardiology, Jayadeva Institute of Medical Sciences, Bangalore. They have an active teaching program, DM Pediatric Cardiology program. There are only 3 centers in the country. They have 2 students every year. He has got a lot of publications. One of the most important recent publication is on beriberi in children. Professor Jairanganath, can you please share your screen? So he is going to talk on management of critical congenital heart disease in infants.
Thank you, Dr. Nageshwar Rao. Let me thank Dr. Bhaskar sir for giving me this opportunity to share some of our experience. Most important, I can say just probably need to sum up the whole thing because most of the diseases have been covered by Dr. Nageshwar Rao, subsequently Dr. Bhargavi, Dr. Kavita. Very, very nice, almost elucidation of the whole thing, scenarios. So let me not waste time. So shall I move on to that? So this is the incidence is almost 7 to 8 per 1,000 infants. Most of the things have been discussed. CHD is the primary cause for prenatal infant death from the congenital birth defect. So these are all critical conditions where I think most of you know that, because almost every single condition has been described, covered in the previous speakers. Let me directly go to the TGA. This is the most important cause because it's almost a cure for the child if you intervene at the proper time. And the diagnosis of late is not very difficult, though it gives you some clinical clue, but the echo is the most important mainstay of the diagnosis. Here you can see that the left ventricle gives rise to the pulmonary artery. This is very, very easy to diagnose. And this is a nearly life-saving condition where we need to identify. Most of these cases nowadays have been identified antenatally. If they miss the antenatal diagnosis, subsequently the postnatal diagnosis is not very difficult by even any simple echocardiographer also. It's only condition where you cannot miss it. So a lot of things you need to see here. There is a VST is there, AST, PDA, or the LVOT obstruction, or the pulmonary stenosis. We should remember what we need to, because the child is born with TGA, cyanosis is there, terrible cyanosis, PDA may be not very big, the ASD may be very small. In such cases, some of the procedure as an interventional cardiologist we need to do. If the surgeon is ready to take up the second day, third day, most of the cases can be done. Some cardiac surgeons do on third and fourth. They don't wait for a week or 10 days, which used to be in the past. Most effective mixing is the ASD level. If the ASD is not there, we need to do some procedures immediately if the surgeon is not ready on that particular day. The treatment, only the diagnosis of the TGA itself is an indication for a surgery. It's mainly surgical. The arterial switch, if there is an intact ventricular septum, arterial switch, which is the definitive form of the treatment, ideally should be done before 1 month of age. But we do extend nowadays in most of the centers up to 2.5 months, and 3 months, depending on the LV size. And if there is a VST, we would like to operate before 3 months, even as early as 4 to 6 weeks, or definitely before 2 months of age, because these people will develop a very, very accelerated pulmonary vascular flow disease, very rapid progression. So that means they become inoperable. So we should not allow that to happen in any kind of a condition. This is one of the most critical care we need to give for an infant. Emergency balloon atrial septostomy done in infants with inadequate mixing, of course, not very common nowadays, probably, but in the public hospital setup like ours, we still do the balloon atrial septostomy because of the workload is too much, the waiting list is too much. So the surgeon may not be on that particular day when he wants to wait. A lot of children do come with us along with this particular problem, neonatal sepsis. So we don't need to wait for 2-3 weeks. So we resort to the balloon atrial septostomy. Still, this procedure is a wonderful procedure. What you see here, using a balloon, enter the left atrium and then give a tug on the septum so that it creates a more large AST. So this is a balloon atrial septostomy. The next condition is being described by Bhargavi, Dr. Bhargavi and Dr. Kavita nicely, that TAPVC. There are 4 types, but the most important critical condition where we need to operate on the day of the diagnosis itself is the infradiaphragmatic TAPVC, because almost always they are invariably obstructive. If you do not operate in the 24 or 48 hours, they may die. So once again, it is, I don't say it is a complete curative procedure, but these children do come back with some lot of pulmonary venous abnormality. They are having an intensive problem. But once again, in majority of the conditions, more than 85 to 90% of the conditions, the diagnosis of the TAPVC and the proper treatment is the curative for the procedure. So this is how it looks like. The echo is being described. I don't want to go into the echo. The emergency surgery for obstructive. Emergency means what? Either probably the lactates are going up, the child is not doing well, they need to be, they're obstructive, probably the same day or the next day, once you settle the child. Elective at 3 to 6 months, if unobstructed. If your waiting list is too long, we do wait. Otherwise, we do operate anywhere between 6 weeks to 3 months, which is very good. I mean, nowadays, most of the surgeons do operate. So the timing of surgery is extremely important in TAPVC, because one infection can just bring the child down. So that's nothing like the waiting. There is no benefit in waiting in a TAPVC. Even the child is doing really well, you can operate easily most of the TAPVs after 6 weeks of life. If the vertical vein is obstructed, some surgeons would like to stabilize us, the cardiologists, by doing some kind of palliative procedure, kind of stenting of the vertical vein, which is not very uncommon in a high volume center. So this is one case where we recently did that vertical vein. This is Dr. Nageshwar also has done plenty of these conditions. When you identify the obstruction and put stent, because balloon dilatation will not help, probably we need to put a stent there. So make the child better. Once the obstruction is relieved, they really do well. You could see how nicely the stenting and the pulmonary veins, you can see that. So the third most important is the Tetralogy of Fallow. So Tetralogy of Fallow, though it's a common condition among one of the common most important condition among the cyanotic heart disease, it is not a cure, but still it is a life-saving. They can lead a near normal life. I would say near normal life because it is not a cure, so because they need to have a regular follow-up throughout their life. Majority of the children do need a second surgery or second form of intervention somewhere along the way. But that does not mean that we cannot offer them a good life. Yes, we do offer a good life, provided we do the surgery at the right time. So this is some of the echo. I don't want to detail. So the specifics in tetralogy, what we need to see, the level of the stenosis, the branch P anatomy, additional VSTs, all these things have been discussed. So treatment options, it varies from center to center. Infants less than 6 months of age, if the P anatomy is not very good, or the center surgeon is not very geared up to do the intracardiac repair, or the anatomy is not good, we do the RVO stenting. This is the treatment of choice now today. But olden days, and even in a lot of centers, they do a VT shunt. But VT shunt is how it looks like. You can see the sternotomy wire. The catheter is in the VT shunt in the subclavian artery, nominate artery. It is specifying the pulmonary artery. It's a very nice procedure. Even today, we need to, the surgeon still have to be very well versed with the VT shunt. Of late, of course, because it is proved beyond doubt in the tetralogies and the subsets, we can do RVO stenting. That I'll show you pictures. The surgical palliation is a VT shunt, or some centers do the central shunt. Corrective surgery, 9 to 12 months of age, but it can be done as early as 6 months. What determines the timing of surgery is that total cardiac repair, intercardiac repair is the one and only the PA anatomy. The anatomy is good, the disease scores are quite reasonably good. If it's acceptable, the as early as 4 months or 6 months is good enough. So why do we have to leave the child with that kind of a disease? So otherwise, a lot of centers do anywhere between 9 to 12 months of age. If the child is doing well, they put him on some kind of beta blockers or iron supplements. So this is one of the RVOT stenting. You put a wire across the RVOT and do the stenting. It takes care of the immediate particular problem for the child having a cyanotic spell, and also it promotes the growth of the arteries. So spell, a couple of slides on the spell. What do the triggering factors? The early morning, crying, all these things you people must be knowing. The deepening of cyanosis, the presentation, excessive irritability, tachycardia, tachypnea, seizures, loss of consciousness. So these are all some of the silent points, like in each position. Oxygen, of course, is not the greatest day, but it improves saxony to some extent. Morphine, if it is available, propranolol is not available now. So though it is all the most of the textbooks do give, we do give the other beta blockers like metoprolol or esmolol. The ketamine has dual benefit, you know that. Phenylephrine to increase the vascular resistance, methoxamine, and IV fluids are the most important stay. And the sort of please remember this. Correction of the anemia takes care of a lot of cyanotic spells. If the child comes with a cyanotic spell, so you don't have to rush up for any kind of emergency procedure. You take care of this on the medical management. You improve the PRBCs by giving the PRBCs. Does help. So most of the children can be taken care of by medically, and till such time that we do offer some kind of a procedure. Correct tachyarrhythmias if there are any. So coming back to another subset of tetralogy, the pulmonary atresia. Here it's a duct-dependent circulation, majority of the cases. Of course, the collaterals also will be there. That's a different issue altogether. If there is no major collaterals, it's a duct-dependent, we need to take care of the duct. In the neonatal period, the medical management, till such time, we offer some palliation is a prostaglandin infusion. Transcatheter, the PDS stenting is a wonderful procedure because comparing to the VT shunt, it's got less mortality. The VT shunt is a surgical option. The VT shunt surgical option is almost the mortality rate is still about 8 to 10%, whereas the PDS stenting less than 1%, I can say. So this is the arch. You can see that there is a duct there applying pulmonary arteries. So most of the pulmonary atresia stenting, we use the axillary artery for the approach. Some people do use the carotid stenting, but difficult to go from the femoral artery. So this is how they taken care of the neonatal period. A word about the prostaglandins. It relaxes the smooth muscle interest, temporarily maintains the patents of the ductus. This is the dosage which is given here for PGE1. Ventricular pulmonary circulation 510 nanogram per kg, predominate 0.05 to 0.1 microgram per kg in the pulmonary duct-dependent systemic circulation. Intact IVS. Here, the intact IVS pulmonary atresia, it is slightly different from the VSD situation. Here, the ventricle may not be well developed. the right ventricle may not be well developed. What is specific we need to see in the echo is, are we hyperplasia, are we well developed, the tripartite ventricle, or is only unipartite or the bipartite ventricle? What about the tricuspid valve? What about the regurgitation? Are we dependent coronary circulation? A lot of things we need to see. Once again, the medical management has a role here using the prostaglandins to keep the, then if possible, the ventricle is quite reasonably adequate size. Even if it is a membranous atresia, only the membrane is there, then we can perforate the pulmonary valve in the cath lab. I'll show some picture. Surgically, after the palliation of the patient or the PDS stenting, the later the children can have the RV to PA, and if necessary, the valve is dysplastic. 1.5 ventricle repair where you use the Glenn shunt along with the RV to PA conduit. So here the what we do is that we bypass some of the circulation from the systemic circulation, venous circulation into the PA directly by adding the Glenn shunt. So if the RV is not at all good size, they can't on operation. So this is how the perforation is done. The catheter is in the RVOT. The wire is a stiff wire is passed, and then we serially we balloon dilate and put a balloon to open the valve. So the HLHS has been described by Dr. Nageshwar Rao in the previous slide. This is one of the very, very dreaded particular thing. It needs a really 2 to 3 surgery. The maximum fetal termination rates right now across the world. It's not only unique to India. If the center is geared up to do these interventions, that they need to be started on, because it's just duct-dependent systemic circulation. So we need to start them on prostaglandins till such time the surgery is done. That's the normal procedure. So management is a conservative versus curative. So this is about the HLHS. Tricuspid atresia of various types. Tricuspid atresia could be of increased pulmonary flow or decreased pulmonary flow. I'm sure it must have been discussed. This is here. The most important thing is that the RV is not developed at all. It's predominantly the LV is the main circulation. So if the hypoxia is present in the neonate, the shunt is a systemic to PA shunt or a PDS stenting, which is not difficult to do, because here, unlike the pulmonary atresia VST, the ducts are very simple ducts, regular ducts, and we can perform the PDS stenting with rhythm ease. Unrestricted pulmonary flow, that means where there is no obstruction to pulmonary flow, increase pulmonary flow situation or increase pH. The neonates, it will be in 4 to 6 weeks. Once again, it comes under the critical care issue that we need to do the banding to reduce the pulmonary vascular resistance to pulmonary flow. So truncus arteriosus, it is not very critical. They're not going to die the moment they are born, but the timing of surgery is extremely important here, because unless you do the surgery in the 4 to 6 weeks of life, they develop once again. They're very rapidly the pulmonary vascular occlusive disease, so we cannot operate on them. So that is the reason that truncus arteriosus should be considered as one of the most important critical condition in the newborn and the infants, where the timing of surgery is extremely important. So there are various types. So will be acyanotic, because this is commonly missed. It will behave like a simple VST. You have some systolic murmur. Cyanosis is not very apparent, because most of the saturation will be around 90 to 95% in the younger age group, like the neonatal period. Once the saturation starts falling, then it becomes as low as 80%, 70% once they cross the 3 months of age. Maybe it will be tachypnic, that behaves exactly like a AP window or a large VST. VST closure RV, this is the operation, the timing of surgery is as early as possible. Aortic stenosis, where predominantly we do take care. If there's a valvular aortic stenosis, we need to see what is the level of the stenosis, whether it's subvalvular, valvular, supravalvular. Morphology of the valve, it's a bicuspid valve, tricuspid valve, quadricuspid valve, or a unicuspid valve. Presence of the LV side, just because the aortic stenosis does not mean the LV is okay. So if the LV is not okay, it forms a permafrost kind of a HLHS. So whatever, even if you open the valve, it may not be of a great use. So this is how the valve looks like in aortic stenosis. This is the echocardiogram. Emergency pulmonary valvotomy is the treatment of choice across the age group in the neonatal period, the infantile period, which is not a very difficult intervention, and it is there for last 3 to 4 decades. Pulmonary stenosis, it can be very critical stenosis with the cyanosis, though the right ventricle will be of a good size. In majority of the case of the pulmonary stenosis, it's a really life-saving, it's a near cure, especially if you do the particular condition in the early newborn and neonatal period. They can present with a very severe heart failure. So needs emergency pulmonary valvotomy. This is how the pulmonary valvotomy is being done. It is not, once again, it's not very difficult to do the procedure, and it's a near curative if you do with the proper balloons and proper techniques. Coaptation of aorta is a duct-dependent systemic circulation. I was hearing Dr. Nageshwar Rao was telling how they present with the cardiogenic shock. So this is the echocardiography. It looks like a very thin antegrade flow. The emergency coarctation dilatation needs to be done. Major out of the centers, the real treatment is surgical option because the rate of risk now of the balloon dilatation is almost close to 30 to 40%. So it's a majority of the centers to perform the surgery. But in our center, we do because once again, due to terrible numbers, almost every week we do 2-3, we get coarctation aorta. We at least a palliative, we do the balloon valvotomy. Tells us time many times we may need to start them on prostaglandin. This is how the balloon dilatation is done. The procedure is not very difficult, but the results are not great. Another condition is we are going to discuss it probably next seminars. The Al-Kappa is once again the most is suspicion of this case on the ECG and on the echocardiogram and how the children present, and it is one of the treatable cause of the LV dysfunction. If you do not take care of that, LV will not improve after a certain time. This is how echo looks like. So come out with some of the case scenarios of a rare condition. They're not very common. 23 neonate, feeding difficulty, breathless diaphoresis, continuous murmur on the chest. There's a dilated right atrium and right ventricle, dilated veins. So this, we thought it's some kind of a echo-wise pulmonary venous strain, which is not. This is a subclavian to the portal fistula. So this is one of the rare condition of the portal vein to the, it's a main ring course, subclavian to the portal vein fistula, presented with a very bad heart failure. So we closed with the device. So it was quite some time back. The child did extremely well. So similarly, 1 more year-old boy, cyanotic. Once again, the suspicion is important. A lot of symptoms, heart failure, cyanosis, both. This is a case of RPA to the LA fistula. The child had both volume overload and cyanosis. This was closed with the device. So this is a complete again graph. The cyanosis also disappeared, heart failure symptoms have gone. Another condition, 45-day female infant, progressive abdominal distension, increased frequency of stools, irritability, excessive crying, ultrasound. This was how it was looking like. Engorged veins, sphenomegaly, other systems are normal. Ascites. Use the abdomen, dilated portal vein, gave some suspicion of the portal hypertension. Arterial pattern of the epidural flow. This is not a like aberrant malformation. This is a large anomalous artery directly opening into the aneurysmally dilated portal vein. So this is done from quite back. And this is closed once again with a device. To conclude, critical congenital heart disease are very common, not uncommon, I can say that. Account to 1/5 of all the CHDs. High suspicion is extremely necessary. 2D echo is necessary for the diagnosis. This is going to be made cardiovascular diagnosis and to plan management. You need to probably apply some other imaging modalities like a CT scan, MRI, and other things. So emergency catheter is life-saving, and the surgery is the treatment of choice in majority of the critical conditions. Thank you.
Thank you very much, Dr. Jairanganath. It's indeed really a very great lucid talk, and lot of surgical managements and its timing has been enlightened by you. I thank you very much. I think we are running short of time. Without wasting time, we'll go to case scenarios, panel discussion. During that discussion, we can answer some of the questions. I'm going to share my screen. Can you please allow me to open? Allow me to share. Yeah. So heart disease in children, common problems. It's a diagnosis and management is the theme. We have panelists, Professor Jairanganath. He just gave a talk and you all know. And we have Dr. Kavita Chintala. She spoke on X-ray, ECG and blood gas. Professor GVS Subramaniam, the Professor HOD of ESI Hospital, Hyderabad, is one of the senior most finest pediatric cardiologists in our state. Dr. Teja Pratap is a neonatologist at Fernandez Hospital, Hyderabad. So general incidence of congenital heart disease, every day 1,000 babies are born in this city. Example, 10 will have congenital heart diseases. 20% are critical congenital heart diseases, which we discussed today. Somebody, okay. Many children, they don't reach the hospital for the management. That's why all these panel discussions, symposiums are important. If you don't treat them, they develop heart failure, or they develop complications due to cyanosis, they develop pulmonary arterial hypertension or respiratory infections and succumb. That's the reason why we need to address this problem. We may miss congenital heart disease. We were missing earlier. Now the missing rate is not high because of the clinical diagnosis and availability of other investigations. Lack of identification of symptoms, delay in consulting doctors, subtle findings pick up, presentation with respiratory infection and not diagnosing congenital heart disease, improper evaluation by all these means. So we have some case scenarios here. Parallelly also, I'm seeing chat box. 1-year-old child, preterm 28 weeks, hemodynamically significant PDA, closed with paracetamol, bronchopulmonary dysplasia, oxygen dependency, developed heart failure, and diuretics for long time. So this is the chest X-ray, which is showing dilated pulmonary arteries, very significant. You can see that ECG is showing there's a right bundle branch block and a right axis deviation. So this baby echocardiogram showed there's a large atrial septal defect, but fortunately there's no pulmonary artery hypertension. So Tejo is there. Actually, I think their center is one of the center where they treat extreme preterm babies, 900, 800 grams and all. So how often you see this bronchopulmonary dysplasia in association with either hemodynamically significant PDA or other congenital heart disease?
Thank you, sir. So oxygen dependency and bronchopulmonary dysplasia is mainly common nowadays in less than 28 weeks of babies. Previously, it was there in even up to 32 weeks also, thanks to the non-invasive strategies of ventilation, which people are nowadays using, and even the sophisticated ventilation strategies like volume guarantee and other things by which we are able to decrease the BPD a little lesser on this thing. However, still it remains just very challenging cases, especially for the babies who are less than 1 kilo. Almost the incidence of BPD, we can say that around 10 to 15% it will come. However, the case scenario like what you are suggesting, you are presenting, it will be roughly 1 or 2% usually in any year of these things. So this is what is happening right now. But the main problem for developing the bronchopulmonary dysplasia, previously we used to think only the ventilation, but now we know that it is the extreme prematurity and exposure to multiple insults like sepsis,
so bronchopulmonary dysplasia is still a possibility, and you come to see these conditions. Is it correct?
Yes, sir. Yes.
Sir, Dr. Subramaniam, sir. Sir, can you put on your microphone, sir? Hello. Sir, AST, generally speaking, it won't produce a heart failure during infancy. What is your clinical experience of heart failure in AST in young children? And what is the your cardiologist opinion in this? Because a lot of people earlier, AST will not cause a heart failure and we tend to postpone the surgeries for a long time. Can you please give some comments on this heart failure and atrial septal defect?
Sir has to unmute. Sir, you have to unmute, sir.
Please unmute, sir. Yeah. No. Again, unmute, sir. Unmute.
Am I audible, sir?
Yes.
Yeah, you are audible, sir. Very much.
Yes. ASD as such, being a left-right shunt, the OSD type, ostium secondum type of defect, usually not present with failure during infancy. Many infants are asymptomatic. We don't come across. We are likely to miss a diagnosis also in a busy OPD, frankly speaking. But if it is presenting with a failure, the cause should be something else other than simple ASD. Sir. That's what.
Wonderful message you give. Suppose if there is a AST with a heart failure during infancy or young children, it is not AST. It may be due to some other thing. We will discuss, sir. That is what message I want. Kavita, see, we have been teaching to students, everybody AST should be close about 10 kilogram, above 3 years of age. So what is your policy in AST with the heart failure in infancy or young children less than 2 years? Very brief answer. We'll have more cases.
Yeah, I think there is a subset of children, infants that do present with heart failure, which we probably previously did not recognize, and now they need an earlier intervention.
Wonderful, wonderful. Professor Jairanganath, do you close ASTs in your center either surgically or transcatheter? You have a lot of experience with young children.
Yeah. No. It is not uncommon for us to see the small children with ASTs, especially large ASTs coming back with heart failure, because it's a cohort of patients, it's a large number. Say, we do come across at least 8 to 10% of the ASTs do need closure at a slightly early age. The one which you have put on the board, that the preterm PDA close presenting with heart failure with a BPD, there's a fairly large AST with a large shunt. Large shunt itself can give rise to the heart failure. So I think there is enough indication to close this particular AST.
So you prefer transcatheter closure or surgical closure during infancy?
No. Definitely surgical closure. I would not like to put a device. Definitely not at all. The recommended this thing is more than 10 kilo. Definitely, I think we should stick to that rule.
I think the safety point of view, AST surgery is quite safe.
Because it's a very standardized surgery, the time-tested one with less problems. I think you should undergo the surgery.
Wonderful, wonderful messages. I will just show you a case, actually, interesting case. This is a 6 years girl presented with palpitations, tiredness, and fatigue, showed large AST, and we actually thought of doing the cardiac catheter, doing a device closure. We took the child to the cath lab. We found that high pulmonary artery pressures. You can see the high pulmonary artery pressures. And also, interestingly, there is desaturation. You can see the PCO2 levels are high. And we gave oxygen, still PCO2 levels are high. So, very, very interesting. This kind of case scenario, this we also surprised. We stopped the procedure. We evaluated the baby. We were confused what is the reason. Then we found that there is a partial ptosis, bilateral ptosis. Then we thought we'll take opinion from other colleagues. So neurologist opined that it is possibility of myasthenia gravis. So we did a genetic assessment which showed that. So this is because a airway obstruction due to muscular paralysis due to hypercarbia leading to acute pulmonary vascular constriction and all. Why I put this case scenario? In atrial septal defect in children, if they present, it may be due to right ventricular problem. And if you miss a pulmonary artery hypertension, which is going to be catastrophic. Sir, Subramaniam sir.
Sir.
So how often we actually evaluate children with pulmonary hypertension, sending them for ENT for adenoids and tonsillitis? Are we seeing regularly, or whenever there is a symptoms only we do that?
Usually the children between 4 to 8 years age group, they will have a lot of double the lymphoid tissue in the nasopharynx. They tend to present with sometimes sleep issues and also difficulty in breathing. Some of them have even stridor also. But most of these children are evaluated by ENT physician for any upper airway obstructions. But I think there is a need to pay more attention upper airway obstruction causing pulmonary hypertension in children because of chronic hypoxia, more so during sleep, must be paid attention by all general pediatricians.
Jairanganath, you have any unusual case scenarios of AST with heart failure, AST with pulmonary hypertension to share in the forum?
Yeah. Dr. Subramaniam told clearly the adenoids. He also said adenoids. I think we have quite a good number of, we have got the children adenatectomy. We have presented to the AST with a moderately elevated PA pressures. Once the adenectomy is done, I think they've all done well. I think this is, especially in this particular group, the age group between 4 to 8 years or 4 to 6 years, I think we should, each and every, they diagnose a lot of outside people, echocardiographers and adult cardiologists make a diagnosis of PA pressure is around 50, 60 without paying attention to what is the reason for it. It has to be evaluated. It is not very, once again, it's not very uncommon in children.
Fantastic.
I think all BPD patients also should be assessed for PAH. I think that's very under-recognized in that subset, BPD subset.
So the possible explanations for heart failure in children with AST, the larger the normal left large shunt, presence of additional shunts, then lack of decrease in pulmonary vascular things are earlier than usual, or any associated obstructive diseases like pulmonary vein obstruction or ventricular resistance. Suppose right ventricle is supposed to lose its power and it should be compliant. If it is a non-compliant right ventricle, then again there will be problem. Heart failure is quite common. And abnormal atrial compliance or presence of left ventricular dysfunction. All these are important aspects of heart failure. So in these patients, we should be careful in assessing and needs early closure. Let us see case scenario 2, Tejo. This is a 7-month-old boy, fetal echo showed subaortic VST, 25 weeks gestation age, delivered in the month of May during lockdown. Birth weight was 2.9 kilogram and treated for bronchopneumonia at 4 months of age. So this is a fetal echocardiogram, and this is a big heart here. You can see some vascularity and increased voltages, feeding difficulty. If you look at the echocardiogram, there's a large VST. Bhargav also shared same images, and there's a bidirectional shunt is there. So I'm asking you, suppose we diagnose the fetal echocardiogram, VST and all, how do you counsel the family in NICU, number one? Number two, how do you diagnose VST in a non-diagnosed case also?
Sir, in the initial period, suppose though you have suspected a VSD in the fetal echo, but initially there could not be any symptom or this thing, as Dr. Kavita also pointing out that the murmur may appear a little later because the pulmonary vascular resistance will take a little time to disappear or this thing, or decrease. So it will be very difficult in the beginning to suspect any simple VSD or anything in the beginning. However, if you have previously fetal echo which has shown, it is always better that we have to repeat a 2D echo immediately after birth and then see how it is faring now postnatally or this thing. So social issue is.
Yeah, please go ahead.
So social issues, main thing is that parent will keep on asking us that does the child actually require a surgery immediately, or does it require any treatment immediately or not? Why should we go right now? Because the baby is reasonably okay at the time of birth. Because many of these children will be initially for the first 1 month will not have any symptoms or this thing. So it is always important from the pediatrician point of view that the danger will start after 1 to 2 months. Okay, so then the left to right shunt will increase, the chances of pneumonia will increase there, and the child will have more and more problems at this day. So it is always important for us as a pediatrician or a neonatologist when these children are coming for the follow-up to look for the respiratory rate assessment and also to look for any other chest abnormal findings along with the tachycardia and other things, because these are the simple things we can just check with a pulse oximeter while your child comes for a vaccination or this thing, and then check the respiratory rate and send the baby. If all are normal, then we can say that still it is not very active, but you can still go and check for the 2D echo report or this thing. So these are the things that we need to look at it, sir. Marshall, sir?
Have heart failure. So, taught during my MD to have the surgery, recurrent respiratory tract infection should be there. So still are we following in teaching that do we need to have recurrent respiratory infections like at least 6 per year or more than 2 in 2 months time, do you still think that is worthwhile waiting? Because first episode of respiratory tract infection itself is fatal. So I want your comment on that.
Oh, Nakenar, who are you asking? Sorry.
Sir, I am asking Dr. Subramaniam, sir.
Sir, thank you, sir. I think that concept is no longer held valid. So we cannot wait a child to develop repeated chest infections. While as a standard part of teaching, if the child develops a recurrent chest infections and comes with such history, we have to evaluate for a congenital heart disease, more so a left to right shunt. But we should not wait for that history to develop in a child, in a given child. So once there is a respiratory infection, as you said rightly, in the first episode could be fatal. So there is a need for early evaluation, more so with the current available tools. The child needs to be evaluated and find out what is exactly the problem that has caused the child to have developed respiratory infection such an young age, more so. So this is one thing I would like. So regarding social issues, to what Dr. Tejo said, I would like to add some points here, sir, which are of concern for me. For example, when we detect by fetal echo some problem in the fetal heart, I think it demands a lot of skills on the part of the counselor to counsel the mother, because the counseling is not appropriate. It will be sowing seeds of anxiety in the mother's mind and as well as the attendants. So therefore, what exactly is the baby's condition, what needs to be done is to be explained in clear, plain terms, and also see that the mother's anxiety is addressed, because it may have deleterious effect on the mother's health also. That is one aspect. Regarding the placement of delivery also, where the child can be delivered, suppose the baby requires immediate postnatal intervention, what should be the institution where she should deliver? Sure. That also we have to decide. As you said, nearly 25% of the cases, they may need interventions immediately after birth, especially in cardiac conditions. So therefore, the counseling should be appropriate, tailored to the needs of the baby as well as to the mother, and the place of the delivery also should be in an appropriate place. This I would like to add.
So that's a very important point. We don't wait till we define the recurrent respiratory infections. Even single episode can be fatal. Once a baby develops a heart failure beyond a neonatal period, typically between 2 to 3 months of age, child should go for surgery. Dr. Kavita, do you send all the babies for surgery based on X-ray, ECG, and echo alone, or that is sufficient when you are talking about operability?
If there's a pure left-to-right shunt and the saturations are normal, yes, echo is enough. Echo, X-ray, and ECG are enough to send the baby for surgery. If there's any bidirectional shunt, I would evaluate further with the cardiac.
Okay. Jay, I want you to tell people, in the presence of respiratory infection, there is no question here. Suppose baby with a large VST with respiratory infection stuck on ventilation in PICU. So when do you decide baby should go for surgery? Because they can't extubate the baby. Baby is on ventilation, respiratory infection clinically appears better. So this is the commonest scenario we all get to know.
Yeah, it's very common. I would say the total counts are normal. 4 days of afebrile nature. Counts are normal. CRP is a declining trend, or it is near normal. Procal is okay. I think they should operate. They should not wait even a single day.
So you go by clinical and lab, or you see radiologically X-ray also?
No, radiologically also they need to see, but there will be lag will be in the X-ray clearance. There will be some bit of radiological lag will be there. But if there's already a lot of big patches there, we need to wait. Otherwise, if the X-ray is radiologically there's clearing, and if the no septic parameters are suggesting of the active infection going on, I think we should operate. Otherwise, you will never be able to get off the child. No way.
So this particular case is kept because the commonest congenital heart disease is ventricular septal defect, and the commonest cause for mortality in children in structural heart disease is ventricular septal defect, because a lot of fetal scans are diagnosing the complex heart diseases except VST. Those are all getting delivered at tertiary center and going for operation, but still we see a lot of cases coming. Typically you see this 4-year-old child coming from Mancheriala, and this baby was diagnosed as VST and PDA, which was not diagnosed actually. And you can see the chest X-ray here. There is some cardiomegaly, but there is no left ventricular apex. There is a little bit of a plethora, and you can see the ECG still showing that. But when we did the cardiac cath, the pulmonary artery pressures are very high, 64/40 versus LV pressures of 89. We calculate the pulmonary vascular resistance, which is very high for the surgery, the baseline, which is 16.7, whereas on oxygen it is 8.7. It is not operable. So this is a very pathetic situation to have such kind of cases still when we are talking about availability of pediatric cardiologist, cardiac echocardiogram and all, because it was missed because of the clinical scenarios were never picked up because of the respiratory infection or for some reason somewhere in the remote village. So this is a very important in the natural history of VST. Why I asked mother why it was not operated. She said doctor diagnosed it during infancy, heart disease, sent for surgery. They waited for 6 months. Then baby became asymptomatic. Then they thought VST is closed, naturally closed. So what happened? Baby initially will have left right shunt. They have heart failure. They develop respiratory infection. Once they develop a pulmonary artery hypertension, left right shunt will come down. They become asymptomatic. A symptomatic baby is coming into asymptomatic state. Actually, it is dangerous, especially in ventricular septal defect. So it is not the doctor's problem. The tendency in society is they try to blame the doctor that the doctor never advised. Actually, in reality, it's a natural history which actually confused the family and the physician that the baby is asymptomatic. So this is dedicated to Professor Jairanganath. A 4 months infant presented with respiratory distress, saturation low, tachycardia, and tachypnea is there. We did the echocardiogram. So I want you to comment on this. So how do you approach? Professor Jairanganath, you have publication. It's not that you can't diagnose, but we want you to hear from you.
No, this is a typical scenario. Anywhere the child from 3 months plus to up to 8 months or 9 months, the presentation with they will have a cry, very shrill cry, very tachypneic, not feeding well for a couple of days, maybe 8 to 10 days. This is a very typical nature of the children, slightly well-grown children many times. But very typically they come to the echo, OPD, RA and RV dilated, and there is a PFO, may not be a PFO. PFO is there shunting right to left, or many times left right shunt with the PF pressure is subsystemic. It's a typical nature. You ruled out all the other cardiac causes. Most important cardiac cause we need to rule out in this condition is a TAPVC. So if you ruled out a TAPVC, if you ruled out other causes like coarctation of aorta or other lesions, causing this, any kind of left heart problems like artery, so many conditions are there. I think typically we ask them, where are you from? Majority of them from, fortunately or unfortunately, they are from Karnataka, Andhra Pradesh, and part of Tamil Nadu. We know the geographic area where they come. Predominantly, you take the history, there is some kind of a taboo will be attached to their family. This invariably, I can say, we can treat them with the thiamine deficiency problems, give thiamine and the OPD basis. Nowadays we give the treatment on the OPD basis. We don't even admit them. We send back after a couple of hours. This is thiamine-induced pulmonary arterial hypertension. The most important in our part of the country.
So this baby came from Nalgonda. We have more than 100 infants, exclusive breastfed babies. We feel that eating rice is a status in the society. Earlier in Telangana, before our late Chief Minister Nandamuri Taraka Ramarao, they were eating jar and other maize, all those things, which was rich with thiamine. Now what happened? Introduction of 2 rupees rice and government programs, water, everybody is cultivating only rice. It's not available no more. It is available in our Telangana state, and everybody is eating a white long rice. They feel it's a status symbol 3 times in a day, which is absolutely lack. So what we found that in the mother as well as the baby, extremely low thiamine levels. You can see that all cases, extremely low thiamine, even fetal beriberi we are seeing nowadays. Actually, my colleague Shweta is with the manuscript of that. So this is a typical thiamine deficiency, beriberi, which we see, and thanks to Dr. Professor Jairangnath, they published it. We are also coming with. My question to Subramaniam sir, how do you prevent this epidemic? What are the measures by the government and IAP? What is your suggestion?
See, South Indian rice eaters are mostly they consume polished rice, sir, which is devoid of B1. So there need to be good supplementation of B complex group of vitamins, especially right from prenatal period onwards. And I got some small submission here, sir. Is there a need for giving a therapeutic trial with B1 in all the children who are presenting with failure in early infancy? Is there any place for it? As a cardiologist, what is your recommendation?
I think if there is no heart disease, ventricular function is normal, that left ventricular function, a disproportionate PAH or a heart failure which it doesn't have any cause should be given. Now, empirically, we all are giving. We take a sample, but we'll still give thiamine irrespective of that. That's a wonderful point.
Yes, sir. Because pyruvate is converted to lactate, and mainly the babies, they tend to develop high output failure with acidosis, and usually associated with pulmonary arterial hypertension also. They tend to respond dramatically if B1 is given intravenously or even orally also. For intravenous, there is a quick response within 12 hours to 24 hours.
Teja, do you see the case with high drops or anything responding to thiamine in your practice?
High drops till now we have not seen, sir, but very early heart failures we have seen even up to 2 weeks also, which responded very well to thiamine. That's what I can say. But high drops till now I haven't seen, sir, but that's a new for me also. But very early, as Dr. Subramaniam sir is also asking, we also, for some of the cases where even the preterm babies who are growing, and then if you don't have features of so much features of BPD, but still the baby is having that right heart changes with pH and other things, I think sir's team is supporting us. And then when we ask them, we are giving a trial, and some of them are actually improving to a larger extent.
So any age group with a heart failure, undiagnosed condition, no etiological factor, it's worth giving a thiamine even.
Yes.
So there is a 6-month-old infant weighing 5.7 kilogram presented with a heart failure, diagnosed as myocarditis, referred for the treatment. Dr. Kavita is there. So this baby was having a very low voice. This is the cardiomegaly. Dr. Kavita? Okay. Anyway, so you can see that the baby is having a very low voice, delayed milestones. There's a cardiomegaly. If you look at the ECG is showing a high voltages here and a short PR interval. Short PR interval. Dr. Kavita, you are there. You can see that. So
I think she left, sir. Yeah.
So, Jay, you can discuss the diagnosis. We will ask questions with Tejo.
Yeah. No, ECG was very classically, there are a lot of biventricular forces, as you showed in the ECG, previous ECG. Yeah, you can see that. You said the short PR interval. It's both the combination of both right ventricular and left ventricular, predominantly a lot of LV forces are there. I can't see the LA enlargement, I couldn't see. Anyway, it doesn't matter. There is a cardiomegaly in the X-ray. Then echo, you could see that there is a severely hypertrophied left ventricle, concentric LVH, definitely. So you see the whole cavity, LV cavity is very small. So this here, we need to consider a lot of, of course, we need to rule out there is no aortic stenosis, there is no coarctation of aorta. The secondary causes of the LV hypertrophy. But infant of diabetic mother, they will not have this amount of LVH. No, they will not have this amount of LVH. So we need to think of some kind of a storage disorder. As rightly you put it, I think we need to consider the storage disorder.
Absolutely correct.
Even facial features of the baby is also a little dull, like with failure to thrive, with muscular symptoms are also could be there. So those are the things that we need.
Tejo, these questions to you only. So how do you counsel the family? You can diagnose POMPs. What is the role of enzyme therapy, and how do you actually diagnose prenatally? These are the common. It is not a rare POMPs disease. We see some 2 to 3 cases per year. Maybe a lot of cases which we are missing.
I do agree with you, sir. A lot of cases nowadays needs this evaluation and other things. See, this classically fits into that infantile onset Pompeii. This is where the onset is very early with the cardiac symptoms and also the failure to thrive symptoms which are there in the kids. So in these kids, if you start the enzyme replacement therapy very early, the chances of reversal of the first thing is that deterioration will not be there, that's for sure. But reversal of symptoms are also a little possible with the enzyme replacement therapy. Only in few cases the children can get antibodies cross-reacting can be there, where the other therapies can be given along with this thing. This one. So if you have a previous kid with Pompeii therapy, we need to go prenatally with the chorionic villus sampling as early as possible. If it is missed, then at least the amniocentesis can be sent early so that we can do the genetic diagnosis immediately on this thing.
Summarize that. I think it's very important to tell that late presentations are common in these cases. Above 6 months of age, it is not possible to give enzyme replacement. Even if they come, it is not fully established. Once a baby develops Pompe is diagnosed, it's a mandatory to have, because we have a family with 2 babies with Pompe. So I rightly agree that organic villi sampling is needed.
Sir, one point here, sir. When you have, like sir also suggested that if it is an infant of diabetic mother, then there will be a little confusion whether this is a Pompe or this one. So till how many days we need to wait before sending a whole genome sequencing, or do we need to send in a significant cases straight away on this thing?
In the interest of time, I will skip off a couple of cases. I will go to case number 6. 8-year-old boy with a history of syncope in the morning prayer. While in the assemblies at the school, this is what syncope is. Sir, Subramanian, sir, how often you come across in your practice that children with syncope, and how do you actually educate your students or family?
Syncope is quite common, sir. Vasovagal syncope is the most common variety we come across. Very often they are confused with sometimes with seizures or absent seizures or something else. And children, they tend to, after prolonged standing, sometimes they become hypotensive. Once they lie down in supine position, they tend to recover. In spite of presenting with the classical presentation of vasovagal syncope also, we try to do the necessary workup, which include the baseline ECG, blood sugar estimation, and also blood pressure. And we try to assess the child neurologically also for any neurologic cause for syncope. And if nothing, most of the cases prove to be simple vasovagal syncope only. And one important point is when the heart rate also slows along with syncopal features the child had. And that is one feature which will help us to understand that is syncope. And by the time the child immediately regains consciousness once he is made to lie down supine. That's one.
So this is what typical how it actually the response of heart rate and BP. There will be initial rise in heart rate, then fall in heart rate along with BP, because vagus nerve will be stimulated, leading to the syncope, and then be spontaneous recovery. So this you see many situations, like when you see blood, when you hear a abnormal message that somebody died or accident. So these are all cough syncope. Then a lot of situational syncopes are there apart from that. So it's important to evaluate these children, because sometimes the structural problems like critical aortic stenosis, idiopathic pulmonary hypertension can cause syncope, and we often make the gravity of the situation thinking that it's a vasovagal syncope. What we do is first we evaluate that clinically, and most of the children, they will be all right. Then we do a test called a head-up tilt test. We make them to tilt and then demonstrate in the lab that whether he is developing the syncope or not. If that is there, then we encourage them to avoid prolonged standing, do tilt training. Make child to learn the tilt training over the period of time. That is the treatment, because medications doesn't work in this situation. So there are a lot of other things which we can actually evaluate in that. Probably this is Professor Jairanganath and Dr. Subramanian sir will talk. This is a 16-month-old child presented with a fever for 2 weeks, irritability, congenital congestion, received IV gamma globulin, high dose of aspirin for 8 days. in view of progressive coronary dilatation, child was given monoclonal antibodies. You can see the coronary arteries which are quite significantly dilated. G scores are +7, +8. Kawasaki disease with the coronary uniform dilatation. There is no focal aneurysms except that. So my question is, what is the practice in Jaydeva or in Bangalore when you have a progressive aneurysmal dilatation, whether you give gamma globulin or you consider first line therapy, monoclonal antibodies as a first line therapy? Jai Ranganath.
So, I mean, to be honest with you, so the moment we diagnose, this is our standalone cardiac center, our hospital. Okay. The moment we come across any kind of a suspicion of the Kawasaki or Missy or anything, we send them to the Indira Gandhi Child Institute. I think they take care, but we do give very rarely. We have given IgG monoclonal antibody. I don't have much experience in our hospital.
Okay. So what we feel is we give gamma globulin only. But when our child presents with really giant aneurysms and the active phase, probably that's the time to consider monoclonal antibodies in those situations. Actually, I want to ask Subramaniam sir, when you are diagnosing Kawasaki disease, you dependent on cardiologist always and echo, or you diagnose clinically and give gamma globulin? What is the current practice in our Hyderabad?
Ideally, it should be seen by cardiologists, sir, before we draw any conclusion. But these conditions like pandemic, sometimes it cannot be feasible. One has to go based on clinical assumption of the diagnosis and start treatment. That's but in general, it would be better if in case is seen by cardiologists.
Sir, the sensitivity of the picking up the things on the echo, the coronary dilatation in the initial phase of the Kawasaki is very low, sir. Very low. I think we need to give a lot of importance to the clinical suspicion also, because we have seen first week, second week, we don't see the coronary dilatation. They maybe start dilating after 2-3 weeks.
Suppose patient is in Adilabad, because I am telling you realistic scenario. Typically, clinical features of Kawasaki, they still want opinion. There is a probe limitation. It's adult probe. The operator limitation, lack of knowledge on that, going to cause a serious problem. I think since you are in Hyderabad, you are surrounded by cardiologists, you are in an institute, probably you don't feel like you always take support, or you feel that your confidence levels will be high to have the echocardiogram. But whenever people are there in the remote area, I think we have to go by the clinical criteria.
Yes, there is no harm in giving, by giving there is no harm. By not giving there is a harm. So therefore, I think by they are from a remote area, better to give based on clinical assessment.
How often you see neonatal KD? Did you come across any case, or you are still waiting? I believe that your center published 2 cases report recently. So can you please tell me very briefly, very quickly you can tell?
Yes. So 2 cases we had last year, which had a little initial features of non-human head drops in the fetus, and then the baby started developing the significant pulmonary hypertension and other things in one of the case. So these we attributed initially to either it should be a MIS or a neonatal Kawasaki disease, and then we started giving the IVAG in one case. In both the cases, one case I think we could not able to salvage, but in the other case we were able to manage the case of this thing. So it's not very uncommon to have the features of Kawasaki disease in the newborn period also. With the pandemic, especially the COVID, there is an overlapping picture of both the multicystic inflammatory syndrome, newborn, and the KD, which is there. And I think Sir has shown us the first time the giant coronaries which were there in the one of the kid. This thing that's very rare. Yeah.
I think I will put a last case, just 2 minutes, and then wind up because we don't have time. This is a preterm 32 weeks history of sudden infant death in family. Fetal echo showed sinus bradycardia. This is the ECG. I request Professor Jai Ranganath to give a comment on this, and he can probably leave because he has to go. He requested me.
No, this once again, the suspicion is extremely important as you clinically, you have given the history that there is a history of SID, a sudden cardiac death in the family. And with that, any bradycardia for that matter, any bradycardia, neonatal bradycardia, not necessarily preterm, any even full-term child with a bradycardia, they have to be investigated for a long QT syndrome. Here, very classically, you're showing the QT is more than 520, which is phenomenal, and there is a significant bradycardia. So I think this needs to be addressed properly. Thought of the QT syndrome, once again, it's a very life-threatening condition. I think suspicion is the most important thing, and it is not very difficult to make a simple ECG, and that gives enormous information. Yeah.
Thank you very much, Professor Jayannath. I will ask Tejo, maybe on behalf of IAP TCB, we really profusely thank you. Since you put a request that you want to leave, we will proceed with another couple of questions. Tejo, this patient with a history of SIV, number one, why you people ask echo rather than doing ECG, number one. Number two, do you do genetic test in these patients? And what is your algorithm?
Sir, I think the echo, I don't think that we need to be first line in these type of cases. First thing is that any unexplained infantile deaths or neonatal deaths in the family, if you have a history of any of the siblings having the childhood deaths or adolescent deaths with typical history of post-exercise and other things, sudden cardiac events, there I think we need to definitely advocate to screen for this long QT syndrome at this stage. That neonatologist is that because many of the times children with the cardiac disease we might miss because in the routine examination. That's the reason why maybe 2D echo might have been asked. But as a unit practice right now, what we are doing is that any neonatal deaths in the previous pregnancy or in their immediate family history, and even the stillbirths and other things are also, currently we are doing an ECG and a screening 2D echo and a neurosonogram as a routine in our unit right now. And
I saw that you found a lot of long QTC in your unit. That is the reason why I'm asking this question. I saw that you found a lot of long QTC in Fernandez Hospital. That's why I want you to give a message to all that ECG is important.
Yes, sir. That's the reason why we do pick up these cases very early in the period, and then we can advocate some of the children with the pharmacotherapy and other things where we can prevent these sudden cardiac events. And the typical history will be the previously the children was reasonably okay and sudden death was there, or baby was shifted to mother's side on second day, third day, the child died. And these are the things usually we, in the second pregnancy at least, we need to be careful. And even I think if you remember 2-3 cases, we presented in the NNF group also with a genetic diagnosis also with the previous family and other things. So it is very important, very underdiagnosed, and I think I can say just we will dump it as a SIDS and then we will not diagnose anything else. I think that's the main thing, sir.
Sir, Subramaniam, sir, see, this long QTC is coming now more commonly because everybody is taking ECG. So we, as a pediatrician, I am also basically a pediatrician, we give a lot of medications, anti-emetic, antihistamine, all these things. How do you control the situation from the pediatrician point of view, erythromycin group or anti-emetic, and how should be avoided? How to educate the patients and the family?
So there is a lot of self-medication, especially with regard to antihistamines, over-the-counter medications, sir. There is a risk of sudden death with this type of syndromes, I believe. I think public should be educated about the probable implications of using medication, self-medication, like especially with drugs like antihistamines. Public, not alone public, even the profession also should be aware of the limitations of the various medicines that are used in day-to-day practice. So there should be some restriction of the sales also over the counter with regard to drugs like antihistamines. So this I would like to convey.
I think wonderful. It's a really very great session. There are a lot of learning points, teaching points. Subramaniam sir, Tejo Pratap, Professor Jayannath, Kavita Chintala, and Dr. Bhargavi. And also I thank Dr. Bhaskar, Dr. Krishna, and all IAP officials. Thank you very much, sir. We'll close the session.
Thank you, sir. Thank you on behalf of Iaptcb. I congratulate and thank you all people for ending the session in time, which never happened earlier. I really appreciate that. And special thanks to Dr. Nageshwar Rao, sir, for coordinating this interesting symposium. And he started as an opening batsman and kept a good momentum for the entire symposium. And special thanks to Dr. Bhargavi for her crispy, precise, in-time presentation about the complicated topic for general pediatricians like me. 2D echo, she made it so simple and so educative. Thank you, Dr. Bhargavi. And thanks to Dr. Kavita for her effective and illustrious presentation on chest X-rays, ECG, and pulse oximetry. And thanks to Dr. Jaya Rangana, sir, despite his busy schedules, on request of Dr. Nageshwar Rao, he had obliged to participate in this, and he had shown his experience and wisdom, and especially made this interventional cardiology very informative to us, made it very interesting. And special thanks to appreciate, one more appreciation is, all the time or most of the times the panel discussions are pre-planned, pre-edited, but this time I believe it's not a pre-planned, it's a time was not given to the panelists, no time. It was a natural panel discussion. It shows the expertise of the participants like Dr. G.V. Subramanian sir, Dr. Tejo Pratap, and others. I'm thrilled. And 2 hours, 20 minutes passed away just like that. So special thanks to all of you, and as well to the participants who had with us since morning, around 50 persons, and on YouTube, I don't know, Dr. RS will be knowing. I sincerely thank you all. I know how difficult it is to prepare the topics, prepare the presentations, to attend the symposia. My sincere thanks on behalf of entire Iaptcb executive body. Thank you all.
Thank you, sir.
Thank you, sir. Thank you.
Thank you. Thank you very much. Dr. Vamshi, are you here? Dr. Vamshi, are you here? Right. Thank you, sir. Have a happy Sunday.
Thank you.
Family members.
Thank you, Bhaskar.